and the last day of this.
Yeah, now Priya, you start.
Namaste and welcome everyone for this wonderful day 3 of our course. Now this course has really gained a lot of popularity, as what Dr. Lakshmi is getting in all her personal chats, that the course is good and course model is good. And what we found in this 2 days was that every doctor wants to stay back. It's staying back till the end. So that's something really encouraging us. So without any ado, we will start our today's day 3. Now, day 3, after going from day 1, see, day 1, we took up the topic of overall understanding cervical cancer, prevention strategies. We went through many guidelines and we came through no overall. Then second day, we came up with, now when we know overall, we want to now talk about the clinical relevance of various screening tests. Like when you take a test, what's the clinical relevance? And the day 3 today is pertinent to how do you, after screen positives and all, when you do a colposcopy, how you detect it, what is CIN, how do you detect, how do you treat? And then end we are going to do with a case-based discussion, that is amalgamating all the 3 days into case-based discussions, like clinical utility of what we have done. Now the 2 days had a wonderful pre and post evaluation, and there were a lot of enthusiasts who were doing it, and even we have also giving the exams. So these are not exams, believe me, dear friends, these are real fun. And again, today we do have our test first, and I'll request Dr. Bhagya Lakshmi to first conduct the test, and then will be the revision done by Dr. Mala of the day 2. Then we will be inviting our chairpersons, and then we start with our scientific session. First, little remark from Dr. Lakshmi ji before we start.
Thank you so much, Priya. I welcome all our esteemed audience, convener, series convener, co-conveners, and all the esteemed our faculties and chairpersons for day 3. That is our final day of this 3-day certificate course on preventive oncology, that is on cervical cancer elimination. And I am so happy as ICOG chair that we did this course in the month of January, which is Cervical Cancer Elimination Awareness Month. And I'm so happy that at FOGSI ICOG, we are just contributing one drop in that ocean, and we have joined hands with WHO towards their global call for cervical cancer elimination. So with this, I would like Priya to start with the scientific sessions.
So now first will be with Dr. Bhagya and Jignesh. Dr. Bhagya, you can take it, and Jignesh will be then sharing the thing. Over to Dr. Bhagya Lakshmi, my co-convener.
Thank you, Dr. Priya. Thank you, Dr. Lakshmi, for this grand success of the yet remaining session. So request Jignesh to please post the pre-test link in the chat box. Jignesh, is it there? Yeah.
Shared, ma'am.
So, yeah. So friends, kindly go through this assessment or fun, whatever Dr. Priya tells. It's not a test. So please go through it. You'll have 10 minutes for that. We'll be showing the timer. And during when you're attempting the questions, we will all be muted, so you are not disturbed. And please do it. And the same questions will be repeated at the end again. Mr. Jignesh, can you post it again? Some people
have started the timer also. He has posted the link. And friends, this is just a self-assessment. So just enjoy.
Dr. Lakshmi.
Hi, Kiran.
Hello. Yeah. Actually, what happened, I was in confusion for 27th. So today is another session. So I'll join. I will be there. But maybe in between, I'm not.
No issues. No issues.
Yeah.
So let us mute we all. Let us
Jignesh, please
let
mute
our
everyone.
audience solve the questions. Yeah.
Time up. That's done. And don't bother if you people have joined. Some people have joined late and the request is send the test link. Don't worry. Don't get bothered. And now, because we will be starting the scientific section, and then you will be getting the same thing in the post this thing also. So now we would want Dr. Mala to do the revision of yesterday's day 2.
Good evening, everyone. Welcome to today's edition of this excellent online course as designed by Dr. Lakshmi and Dr. Priya. Yesterday, the first lecture was on HPV as primary screening. Now, WHO has advocated HPV as a primary screening wherever it is feasible and the resources present, they should be done as a primary screening because there is a definitely advantages of it. It is cost effective with good sensitivity and specificity. Bethesda revisited because we all know all over the world, one system is followed and that is Bethesda system. This has a quality control and it is very protocol wise, it has been done. So everybody understands the cytological report in the same manner. And yesterday, the treatment of various abnormalities of the cytology in different age group was also discussed. Third lecture was on tissue biopsy of CIN. Here it was discussed how E6, E7 proteins of HPV virus, they help in oncogenesis. The virus integrates into the host cell, host DNA, and then replicates, and ultimately by suppression of P53 and retinoblastoma protein, they go on multiplying and the cells become immortal. So the infection persists and the abnormality persists in the system for a long time. The fourth lecture was on VIA, and we all know it's an excellent novel method and simple method for a low resource facilities like present in our country. It is so simple to perform, simple to use, and definitely the sensitivity of VIA is great. The next lecture was on villi. It was discussed how to do villi. And again, villi is again a novel method of screening cervical cancer in low resource facilities. It's a simple method with great sensitivity. IHC tumor markers, these are very important aspect or in oncology because here we do the immunohistochemistry of different tumors and we plan, diagnose, and we can also plan regard the improvement in the adjuvant therapy in the patients who have had surgery and what adjuvant therapy we can do to them. Now, there is a augmented screening with new AI device. All artificial intelligence is coming in all our fields of science as well as medical field. Artificial intelligence definitely will help us in screening and deciphering the various abnormalities that we face in the cytology smears as well as the tissue smears. Then setting up a colposcopy unit, what are the prerequisites, what are the basics that you require, and how this colposcopy unit can become viable for the general population. This was discussed in our setup. And finally, there was an excellent talk about the digital reporting with SSNPP app. And we came to know about the plus points of this excellent app and how you can use this app in the day-to-day practice and how we can deduct Indian data of screening of cervical cancer through this app. And finally, there was participant interaction with after the post-test. And we ended yesterday's program with lots of satisfaction and lot of learning. Over to you, Dr. Priya, to carry on the scientific session.
Yes, so thank you very much, Dr. Mala and Dr. Bhagya to conduct the pre-test, and Dr. Mala for giving the revision. So today we are on the day 3 of this fantastic course, which has really gained popularity over these 2 days. And I hope that even today, all the speakers would be doing fantastic job. And before starting, I would like to give regards to Dr. Charmila Yau, who is actually the whole series convener. Myself being the course convener for this course, Dr. Bhagya being the co-convener along with Dr. Mala and Dr. Revati. We had on the first day inaugurated by Dr. Rishikesh Pai, the blessings and Secretary General FOGSI's blessings being given. And the main person behind all these things is the Dr. Lakshmi, who is the chairperson of ICOG, along with Dr. Parag, who is the vice chairperson, Beniwale, and Dr. Ashok Kumar, who is the Secretary General of ICOG. So we start our day 3. Now, chairpersons for today are Dr. Sheila Mane, who is currently DNB faculty at KCG Hospital, Bangalore. She is the ICOG Governing Council member and president of ISOPAP Society, Bangalore. We have with us Dr. Kiran Pandey, who is the chairperson of Medical Education Committee of FOGSI, professor and ex-HOD Department of OBGYN, GSVM, Medical College, Kanpur, and Dr. Ashwini Bhalerao Gandhi, who is a consultant gynecologist, PD Hinduja Hospital, Mumbai, and National Joint Treasurer of IMS 2022 to 23 with President Mumbai Menopause Society 2019 to 21. Now, the rule, what we have been following over these 2 days are, we are dividing our topics between these chairpersons, and each faculty gets to have 18 minutes timer will be on, and the timer, Jignesh will be having the timer, so kindly curtail your talk till that. I mean, we'll have a lot of time for discussion. And another thing will be the chairpersons will be chairing the first 3, like Dr. Sheila Mane will be chairing the first 3 talks, and
today
then
there are
post that
only
3 talks.
Priya, there are only 6 talks. 2 talks.
So we'll have two talks. We will have two talks. Yeah. So Dr. Sheila Mane will be taking up the first thing of Leela. She will be chairing the first 2. Dr. Leela Digumarti's talk along with Dr. Geetanjali's talk, and then she will give her expert comments. Similarly, the next speaker, chairpersons will be taking the next 2 and then the next 2. So there will be proper utilization of time. So now we start our program, and I invite our first speaker, Dr. Leela Digumarti, who is going to talk about steps of colposcopy. Now, she is a gynae oncologist, KIMS ICON Hospital, Visakhapatnam, and presently she is the president of ISSCP 2021 to 23. Over to you, Dr. Leela, and we all want to know about the steps of colposcopy.
Yeah, thank you very much. Let me first share the screen.
And Jignesh, to start the timer, please.
Is my presentation visible?
Yes,
Yeah.
doctor.
Yeah, my audible.
Yes, doctor.
Yes,
Okay.
yes.
Yeah.
Good
Yes,
evening.
yes.
Good evening, esteemed faculty, chairpersons. Thank you very much, the organizing team, for giving me this opportunity to participate in this wonderful webinar. So I'm asked to talk about steps of colposcopy. So yesterday and day before, you understood a lot about the screening and various screening tests. So what is next after doing a screening if somebody is screen positive? So for that, we all need to have some knowledge of colposcopy. So it's a very, very important component of cervical cancer screening. It's actually a triaging investigation for screen positive women, whatever may be the screening test one will be doing it. So it actually permits for careful evaluation of cervix and vagina to diagnose precancerous lesions and in situ cancers. Of course, vulvas also can be visualized by colposcopy, and it is called as a vulvoscopy. I'm not going to discuss much about that today. And colposcopy helps for facilitating the treatment. So for doing all these things, we need to have a structured training. So well-trained and informed providers are critical for performing accurate and safe colposcopy. So that's why Dr. Priya and Dr. Shrikande have organized this wonderful program to train as many gynecologists as possible to be a very good colposcopist. So what exactly is a colposcope? So by now you must be having some idea because yesterday you had a talk on setting up of a colposcopy clinic. So it's nothing but a binocular microscope for examination of the lower genital tract under low power magnification. It's actually a Greek word. Kalpas means fold or hollow. That means that is what we are seeing through vagina. Scope is examine. So it is basically useful for the study of surface epithelium, underlying connective tissue stroma, and vascular pattern of lower genital tract under low magnification. And it was first developed by Hans Hinzelmann of Germany in 1994, whose picture I have kept here. And you are all familiar with the commonly used colposcopes. This one is the binocular colposcope. And this is the digital colposcopes, which many people are familiar with. And of course, now EVA portable colposcopy is becoming more and more popular. So this is just a repetition of what you must have heard yesterday. It's a prerequisite to have a colposcopy clinic. That means it's better to have a dedicated area for colposcopy rather than doing in a very busy your regular outpatient clinics. So if you have a dedicated area, it will be very easy to put the setup very compact, and you will be devoting time and doing it in a very systematic, structured way. It's always good to have a trained team. At least one trained nurse would be good enough to help you in doing the procedure. Colposcope, whatever you can afford to, and most important is understanding your equipment is very, very, very important. And you need to have whatever instruments, chemicals, everything you have to keep ready. Then a reasonably comfortable examination couch for patient, then instruments and trolleys, reusable instruments, chemicals, equipment for treatment. So if you have all these things, it will complete your colposcopy setup. So it's not just again doing a colposcopy, but once you find something, whether you want to treat immediately or after biopsy you want to treat. So all that depends upon the algorithms, what one is familiar with and one wants to follow it. So if you have a complete comprehensive setup, it will be very easy. It is something like a one-stop clinic for women who come to you for cervical cancer screening. So this is just a setup what I have. This is the couch where I ask the woman to lie down, and then this is a monitor where I will be storing, saving the data and storing the images. And these are of course, this picture is from the standard textbook, but you can organize your own tray the way you want, keeping the cusco specula of various sizes, some condoms or gloves if you want to do the lateral vaginal retraction. Then these are the tissueless forceps. These are the swabs for doing the test using the chemicals. And these are the various chemicals what we commonly use: the saline, glacial acetic acid, distilled water, and the Lugol's iodine. So we all know that the distilled water, glacial acetic acid percentage of 5% freshly prepared every day, and the Lugol's iodine, which one can prepare and keep it for a month. So this is how you can organize your tray according to your level of comfort. Then after that, definitely before you start doing colposcopy, you need to know why you are doing a colposcopy. So there should be a definite indication. It doesn't mean that you have a colposcope, you should do colposcopy for each and every woman who comes to your clinic. So the main indications have broadly divided as screen positive women. So if you're doing a VIA or a Willi test as a screen test, if it is positive, you can call them for colposcopy. If you want to further evaluate, then any smear positives, that is a cervical smear. And if you're doing HPV as a screening test, so women who are tested positive for high risk HPV. And sometimes if you have a suspicious looking cervix, or if a woman comes with persistent intermenstrual spotting, postcoital bleeding, or persistent vaginal discharge. So these are the other indications where you will consider doing a colposcopy. And sometimes we do colposcopy for women after treating cervical pre-cancer, depending upon the follow-up screening tests. So these are the broadly indications for doing a colposcopy. So then before actually start doing the colposcopy, we need to understand what exactly is the principle behind doing a colposcopic examination. So we are all familiar with that. We put the woman in the semi-lithotomy position, then put the cusco-speculum, expose the cervix, and we focus the colposcope with the light passing on to the cervix. So what happens and how do we capture the image? So this image, what we see is nothing but the result of the reciprocal relationship between the epithelium and stroma. So when we look at the cervix, we see the columnar epithelium, we see the squamous epithelium, and underneath the epithelium, we know there is a basement membrane and a stroma, and the stroma which is rich in blood vessels. So in the normal situations, in the normal epithelium, whatever light we focus onto the cervix, everything goes down through the layers of the epithelium into the stroma, and most of it passes through and some of it will be reflected back. So if the light passes through without much problem, and if it reflects back only a little amount of it, then what we see is the epithelium as colorless and stroma as red due to blood vessels. So how much light passes through, how much light reflects back, it all depends upon the thickness of the layers of the epithelium, the optical density, and vascularity and nature of the stroma. So this principle one has to understand why we see normal when there is no abnormality, why we see acetowhite when there is abnormality. Suppose if it is a normal epithelium, normal mature epithelium, the light passes through all layers without any problem. Only a little bit of light is reflected back. That's why you see the normal squamous epithelium as pale pink epithelium, and the columnar epithelium as reddish, because it is only one layer and the blood vessels underneath the stroma are seen very clearly. Whereas if you have any abnormality in the epithelium and if you put acetic acid, what happens is even if you put the light, only less will be transmitted through the layers and most of it is reflected back, and this appears as opaque white. So that's why we see the acetowhiteness when there is abnormality. So this is the principle behind seeing the acetowhite areas when there is abnormality in the epithelium. So coming to the steps of colposcopy, before actually we do any procedure, it's our duty to inform the woman about the procedure, or the lady about the procedure, take the consent. Most of us are used to take written consent in the form of, we do have a standard colposcopy documentation forms. In that also you can take a consent, because the consent would be, it's not just for colposcopy alone. When you're doing a colposcopy, if you want to do biopsy, for all that you have to explain and take a consent. Then most of us are entering the details into the software programs what we have with our digital colposcopes, or if you want to enter as a hard copy into your notes or into colposcopy forms, that also can be done. Then examination has to be done in a very structured stepwise way. Then documentation is equally important. After that, we need to generate the report and explain the lady again what you have done, what you have found, and what advice you are going to give it. So this is nothing but the IFCPC format, where after exposing the cervix, first we need to see if there is mucus, we need to clean it with normal saline. Then usually we turn the green filter and see whether there is any abnormal vasculature. Then after that, we apply acetic acid with the timer. And then after 1 minute of application, we will look into the cervix again. So we have to see the entire cervix, the transformation zone. It should be completely visible. Then after that, we apply Lugol's iodine and again re-examine. So when you are looking at these things, we usually do the general assessment first. Then if there are normal colposcopic findings, then we report it as normal. If there are any abnormal colposcopic findings, we interpret according to IFCPC nomenclature. If it is suspicious, we report it as suspicious. Then we use the sweet score. Then after that, we make a provisional diagnosis, and based upon that, we will decide the management plan. This is the standard algorithm all of us usually follow when we do the colposcopy. So when we first put the speculum and start visualizing the cervix, one of us, all of us have to be familiar with the colposcopic anatomy. So that is very, very important. So we see the multi-layered squamous epithelium and a single-layered columnar epithelium, and beneath is the stroma. So, but when you look at the cervix, you will be seeing like this. So this is a normal cervix, and this is the columnar epithelium, and this is the squamous epithelium, and the junction between the two is called as squamo-columnar junction. So first of all, we need to identify these things carefully. So after identifying these things, one has to understand the concept of transformation zone. So for that, we just need to know a little bit about the squamous metaplasia. So what happens is when in the newborn, what happens is the squamo-columnar junction is very close to the cervical os, and gradually with the production of estrogens, the columnar epithelium protrudes onto the ectocervix, and you will be seeing the so-called ectropion like this, that is the reddish columnar epithelium. So it appears as if the squamo-columnar junction has moved out. Then slowly the columnar epithelium, which is exposed to the environment, undergoes the process of metaplasia. That means the reserve cells will start multiplying and start replacing the columnar epithelium with the squamous epithelium. So as a result, we see two squamo-columnar junctions being formed, the old squamo-columnar junction and the new squamo-columnar junction. And the area between the two is called as the transformation zone, because this is the area where these metaplastic changes keep happening, and that is the area which is at risk of developing into cervical precancer. So if you see here, you are seeing the columnar epithelium, the squamous epithelium, the junction is the squamo-columnar junction. But here beyond, you are seeing some Nepodian cysts. So this area where you are seeing the last Nepodian cyst, if you draw an imaginary line, that area is the transformation zone. That means in the process of the squamous metaplasia, some of these villi will be closed and they form the Nepodian cyst. Sometimes you do see the glandular openings and other, they're not the gland, the crypt openings and other things. So what you have to see is, of course, the transformation zone or identifying these things are better after application of acetic acid. So coming to the transformation zone, it is the area of the cervix covered by metaplastic squamous epithelium. It lies between the original squamo-columnar junction and the new squamo-columnar junction. And the original one is an imaginary, which is identified by the crypt openings and the Nepodian cysts. So these concepts have to be very, very clear when we start doing the colposcopy. So looking at the new squamo-columnar junction, we usually would divide the transformation zone into 3 types. When you see very clearly, you call it as type 1. If you need little manipulations, you call it as type 2. If it completely recedes inside, you call it as type 3. So just one slide about the vasculature. So as I said earlier, the epithelium, stroma, and beneath you have these vessels. In the squamous epithelium, because it is a multi-layered, you may not be seeing the vessels very clearly, whereas in the columnar epithelium, it is single-layered. You will see the vessels like this. And normal situation, the vessels are like a tree branching pattern of the vessels. That is what we see in a normal colposcopic findings. So this is just an image, what I'm just, the 4 steps, what I'm trying to do, have covered here. This is actually, sorry, some overlap has happened. This is when you expose the cervix. This is a lady who has come with a vaginal discharge, and you are seeing a huge ectropion here. So this is the so-called squamo-columnar junction. That is a new squamo-columnar junction. And here you have exposed with the green filter. But you are seeing only some of the normal vasculature, which is becoming a little more prominent, but as such, you have not seen any abnormal vessels. And here you have applied acetic acid, and even the ectropions also will take up the acetovite stain, but it is very transient and they disappear very fast. Then after that, this is the application of the Lugol's iodine, because it is again an immature epithelium. It doesn't take the iodine, and whereas rest of the squamous epithelium, which is mature, it has stained mahogany brown. So usually whatever images you want, you can store, but for giving the reports, if you at least give minimum 4 reports of normal, the cervix after saline, then green filter or blue filter, then acetic acid, and if you see any white, and you can give the marking and everything, and you can write on that. Then afterwards, the Lugol's ID. So like that, 4 images you can give. So that is the basic, very basic steps of doing a colposcopy. So I can conclude saying that all of us need to have a structured colposcopy training. Setting up a dedicated area and time for colposcopy is equally important. We need to know about our equipment thoroughly. Checking and keeping everything ready before the procedure is equally important. Stepwise examination so that nothing is missed out. And more important is you have to audit your practice very regularly. With that, you will know where you stand and you can keep on improving your standards of doing colposcopy. Thank you very much for giving me this opportunity. With that, I will stop. And if there are any questions, I'm happy to take it. And I have to try to cover very basics in the given time. Thank you very much.
Absolutely fantastic, Dr. Leela, and you've really done justice to the talk. And now we move on to our next speaker. Now, the next speaker is going to be, after knowing the steps of colposcopy, now we want to know the interpretation, isn't it? We want to know how to interpret our lesions. So, Dr. Gitanjali, are you available? Yeah. So this is now going to be dealt with Dr. Gitanjali. So I'm going to share her CV with you all. Yeah, Dr. Gitanjali is practicing gynecologist and obstetrician at Mumbai. She's an honorary colposcopist, cytology clinic, AMWI Kama and Ambulance Hospital, Vasanta Memorial Cancer Trust. And she's also FOGSI IFCPC WHO certified master trainer for colposcopy and treatment with cryo and LEAP, and also Golden Jubilee Award recipient of AMWI. So she will be sharing with us and the colposcopic interpretation PPT. So over to you, Dr. Gitanjali.
Thank you, Dr. Priya. I'll share my screen. Okay. Can you see screen?
Yeah. I started screen sharing.
Topic?
No, we are not.
Thank you very much.
Yes, now we are able. Put it in full screen, no, Gitanjali?
Able to see?
If you can.
It's in a full screen.
Here we are only not able to see.
Colposcopy.
Can you put it in slide slaughter mode?
Now, can you see? No.
The lower bar, which is to the extreme right, na? That wedge type of thing. If you can click over there, then becomes slides. The slides go into the sorter. We'll see the full screen then.
Can you see it?
Actually, yeah, now it's fine. Fantastic. Please go ahead.
Can you see it? Okay. Thank you very much. Sorry for the inconvenience. My topic is interpretation of the colposcopy findings. See, as Dr. Patrick Walker has told, the main basics of colposcopy, you require the right terminology to use to explain the lesions, the right equipment, and the supplies. For us, 3 important things to consider for colposcopy interpretation is the skill, which you develop over a period of time, and basic knowledge of colposcopy theory and cervical pathology, partly Dr. Leela has already explained to you, and availability of the right instrument, the right colposcope, right size of speculum, right size of biopsy instrument as a basic requirements for this colposcopy. Before going into this, the goals of colposcopy is mainly you have to exclude the presence of invasive disease. As you all know, the precancerous.
What happened, Gitanjali?
I think she's lost network.
Can you just stop the clock then?
Oh, she's there. I can see Geetanjali, I mean.
I can't see her.
Yeah, now she's here.
She's there, she's there.
Just give her 1 minute. Yeah.
Yeah, we'll give her an additional minute.
I think the PPT went. She's there.
Geetanjali, are you able to hear us? Because you're muted. Number one, you're muted. Unmute yourself.
Ma'am, वो
Geetanjali, we
request
are not
accept नहीं
able
कर
to hear
रहे.
you.
She is not accepting the request.
Now she's unmuted.
Now she's unmuted.
Can you hear me
Yeah, we can.
again? I'm sorry.
Yeah.
Can you hear me?
Yeah, we can hear
We can hear you, but you're,
Yeah.
yeah, now it's fine. Don't bother, start.
Identify the main goal of colposcopy is to exclude the invasive lesion, identify the transformation zone, define the extent, locate, and severity of the abnormal areas. If indicated, select the most appropriate site for biopsy to allow precision in treatment. Cornerstone is you have to follow a systematic approach that includes correlation of the screening test, histopathology, and colposcopic impression. Location of the squamocolumnar junction and the transformation zone is very important aspect of colposcopy. It varies with the age, parity, pregnancy, or use of oral contraceptives. At birth, the squamocolumnar junction is at the level of the external os. As in the puberty and the early reproductive age, because of the estrogenic effect, there is eversion of columnar epithelium. It extends outside into the vagina. And the late reproductive phase, because of the process of metaplasia, it goes towards the endocervix, and at menopause, it is receded inside the canal. As you see, tissue basis of colposcopy, as you know, the columnar epithelium is the single-layered cubicle cells with a basal nucleus, which is thrown into many.
Have you changed the slides? I'm sorry. What should we do?
I think we should start with Sarita's
With
talk.
the next,
At the
yeah,
back end,
Sarita's-
Jignesh can help her, or she can give her presentation to Jignesh or somebody to show. Geetanjali, are you okay with this system? You are muted.
You have to unmute yourself, Geetanjali. Not able to hear you.
Yeah. I have unmuted, but I don't know what's happened. I'm sorry about it.
Will you want to? Nana, Geetanjali, will you want to share this PPT with Jignesh and then he runs it? Till that time, you sort this out. We can have Sarita's talk.
Okay,
Is
I
that
can
okay?
send him on the mail. Okay.
Yeah.
Yeah.
Jignesh,
You
kindly
can
share
send
your
me
mail
the
ID.
email address.
Yeah, I think
Same
we
time,
go
will
ahead.
start with Sarita, and Jignesh, you help out our speaker. Yeah.
Yes,
Sarita,
ma'am.
please. Yeah.
Yeah, so now I sorry for this. Sometimes this technical errors do come. Now we go with the next talk, which is again a very equivalently very important talk with IFCPC reporting system, where Dr. Sarita Bhalera, who is the obstetrician and gynecologist to Breach Candy, Reliance HNH, Saifi Bhatia, and Vadia Maternity Hospital, Mumbai, and she is the governing council member of ICOG, with joint secretary of FOGSI in 2017, and past president AMW and past president of the immediate past president of MOGS. So over to you, Sarita, and we would like to hear from you, IFCPC reporting system. Thank you.
Thank you very much, Dr. Priya, for that very kind introduction. And I'd like to thank Dr. Lakshmi Shrikande and Dr. Priya Ganesh and the conveners for giving me this opportunity. And I'm going to start my slide sharing. I just want to know whether you can see it.
Yes.
Are you able to? Yeah, I'm just putting it in slideshow. Give me a second.
Yes. Perfect.
Perfect.
Yeah, so I'm going to talk today on the IFCPC 2011 nomenclature, how to use this to grade and report your colposcopic findings. And really, I think that this is a very important topic and we can all really master this IFCPC thing. And I'm going to begin with the saying, quotation from James Bentley, who's the past president of the IFCPC. And he says, "It feels good to be working in a field where there is some progress and a positive end in sight. We could actually see an end to cervical cancer in some of our lifetime." So let's start on a very positive note. And I'd like to tell you first, what is IFCPC? It is the International Federation for Cervical Pathology and Colposcopy. It's a very big international body of national colposcopic societies. They have their, the main office is in America, in Alabama. There are many society members. And the aims and objectives of this organization is basically to, standardize terminology, evaluate all the diagnostic and therapeutic procedures in this field of cervical pathology and colposcopy. And they regularly hold world congresses and help coordinate dates of conferences, even with local societies, and they collaborate with affiliated societies. So I think that the IFCPC is really a very big body working in this area. And this is why the IFCPC classification is so important. We have many classifications, but I'm going to today discuss the IFCPC. Now, coming back to what is the role of colposcopy. We want to identify the lesion, we want to guide the biopsy, and we want to plan the treatment. These are our three aims. And how do we do this? Now, the original IFCPC classification was brought by Patrick Walker et al. In 2003. And then Bornstein in 2011. They modified it and it was put into practice in 2012. And their rationale was to compare practices across to standardized terminology, standardized treatment, and very important in the addendum was to discuss excisional procedures like LEAP and to standardize the height and the depth of the LEAP. And the committee looked at a lot of literature and reviewed a lot of things before they came up with this classification. So let's start now with the 2011. Are you all able to see the screen carefully? Is it visible?
Yes, Sarita.
Yeah, it's visible.
Yes,
no?
yes.
Yeah.
Please go ahead.
So
Please go ahead.
Yeah. So I just wanted to check that you can see it. And here, this is the first page. And the first thing that you have to say is that whether your colposcopy is adequate or inadequate. So they have replaced the term satisfactory, non-satisfactory. We're not supposed to use that. We're supposed to say adequate or inadequate. And for example, if the cervix is obscured by inflammation, scarring, bleeding, whatever, then you say that the colposcopy is inadequate and you have to do it at a later time after treating infection, etc. That's the first step. The next step is that we have to, discuss the squamo-columnar junction visibility and whether it is completely visible or partially visible or not visible, and divide it into transformation zone types 1, 2, and 3. And then we have to think first of the normal colposcopy findings. The original squamous epithelium, the mature or atrophic, the columnar epithelium, whether there is ectopy, and the metaplastic squamous epithelium, whether there are Nabothian cyst, crypt, gland openings, etc. So this is the first thing that we have to go in a very regular, organized sequence and report. Now, then when we come to abnormal colposcopic findings, when we are reporting abnormal, we have to first talk about the location of the lesion. Is it inside the transformation zone? Is it outside the transformation zone? And what is the location of the lesion? Is it 1 o'clock, 2 o'clock, 3 o'clock, etc.? Then the size of the lesion, the number of quadrants that the lesion covers, and the size of the lesion with respect to the percentage of the cervix. If it's a large lesion, it may cover its 30-40% of the cervix. And then we talk about whether they are minor changes, major changes, or non-specific changes. In minor changes, we're looking at thin acetowhite epithelium with fine mosaics, fine punctations with an irregular geographic border. In grade 2 or major, we are looking at dense acetowhite epithelium, rapid appearance of acetowhitening, cuffed glands, crypt openings, coarse mosaics, coarse punctations, sharp borders, and 2 new things have been added in this. That is the inner border sign and the ridge sign, which I will now discuss. And non-specific changes may be leukoplakia, keratosis, and erosion, on Lugol staining. So in your mind, we have to focus on what is the abnormality. Is it a minor abnormality or it is a major abnormality? So that is important, or are there non-specific findings? And try to always guide the biopsy, where the biopsy should be taken. So I saw a question, I think, from one of the audience just in Dr. Leela's talk about the transformation zone. And this is to explain about the transformation zone. And this is the type of transformation zone. Type 1 transformation zone is completely ectocervical, fully visible, maybe a small or large ectocervical component. In a type 2 transformation zone, there is an endocervical component, but it is still fully visible, and the ectocervical component may be small or large. In a type 3 transformation zone, the endocervical component is not fully visible, but may have an ectocervical component, which may be small or large. And here you can see a photograph of a type 1 transformation zone. It's fully visible, the transformation zone. So the important thing is to say that the colposcopy is adequate and the transformation zone, say, is type 1 transformation zone. And here you have a type 2 transformation zone where it's partially gone inside. You could use an endocervical speculum to just open up and have a look at it, but you are able to see it. And in a type 3 transformation zone, it is completely receded into the endocervical canal. So here is to show you some pictures. Now this is to show you fine acetowhite areas, geographic borders covering a large area. And here you can also see fine mosaics which are present. And this fine mosaics are likely to suggest a low-grade lesion. Then, so we have features of minor changes, which is a thin acetowhite epithelium, geographic margins, you can see fine mosaics, and there may be satellite lesions. So these suggest low-grade lesions or minor changes. Then we have grade 2, where we have dense acetowhite. It becomes acetowhite quickly, it stays for a longer time, the acetowhite is much more dark, and this suggests a high-grade lesion. Now, what is the inner border sign? This is very interesting. Inner border sign classically presents in lesions where there is oncogenic HPV, and there is sharp acetowhite demarcation in a less opaque acetowhite area. And sensitivity is 20% and specificity is 97% for high-grade lesions. Okay. Now here to show you what is the inner border sign. So have a look at this very, very carefully for a minute. And I'm going back to show you that it's a sharp acetowhite demarcation in a less opaque acetowhite area. But remember that this suggests a high-grade lesion, and the sensitivity is as high as 97% for an abnormal area. High-grade lesion. Then we have what is called the inner border sign, and this inner border sign is also important. And here you can see this ridge sign, which is a thick acetowhite lesion irregularly growing in the squamocolumnar junction, and this improves the sensitivity and specificity of colposcopy. So if you look again, you can see this ridge sign where you can see this thick opaque acetowhite area, which is again suggestive of a high-grade lesion. And here you can see the arrow pointing to the opaque protuberance that is present in an area of white epithelium within the transformation zone. And here you can see again the ridge sign. So if you look very, very carefully on a high magnification, we can see these things. Then we come to abnormal colposcopic findings which are suspicious for invasion, where we look at atypical vessels, additional features such as fragile vessels, irregular surfaces, exophytic lesions, necrosis, ulcerations, or a gross neoplasm. And there are some miscellaneous findings like a congenital T-zone or a condyloma or a polyp or inflammation, which may be a miscellaneous finding. And here you can see suspicious for there's a dense acetovite area, ulceration, and this is suspicious for invasion. Now here, this is the congenital transformation zone, which is a rare condition. It's a non-neoplastic benign condition, but it resembles a high-grade lesion. When you take a biopsy, there are reports where it will show as chronic cervicitis. It is not any sort of neoplasia. So the next part of the IFCPC's classification is to talk about excision treatment types. And here to standardize excision. Now, excisional treatment, when we talk of excision, we talk of large loop excision, we talk of cone biopsy, we talk about needle excision, but all these excision types, the excision specimen is very important, and the length or the distance of the external margin to the internal margin is important, the thickness from the stromal margin to the surface of the excised specimen, and the circumference, the perimeter of the excised specimen. So when we are thinking of doing an excisional procedure, one must think about all these things very carefully. And depending on whether you have a type 1 transformation zone or a type 2 transformation zone or type 3 transformation zone, your excision has to be like that. And you can see that here the circumference for the type 1 is much less, your depth is much more with type 2, and with type 3 to reach that lesion is much more difficult. So you can see in these diagrams also, again drawn by Bornstein, and he says that the type 3 excision, resection of the type 3 transformation zone includes a longer and a larger amount of tissue than type 1 or type 2 excisions, and a significant amount of endocervical epithelium. And if you can see the diagram, you can see how the excision line, you see the upper limit of visibility, you see the transformation zone is beyond the upper limit of visibility, and the excision line has to go even beyond that. So if you see the line drawing also, and we have to think about the specimen, what is the circumference, what is the thickness, and what is the length of the removal. So these things are really very well described in the IFCPC classification. Here now, just to give you a few examples in the last 5 minutes, this is a 24-year-old with a high-grade SIL pap smear. And this is the colposcopy, and you can see an aceto-white area with some punctations. So first, start with saying, is it adequate colposcopy? Then is it, what is the transformation zone type? Is it type 1, type 2, or type 3? Then think about the findings. Are these minor grade findings? And we are talking in terms of grade now. Minor grade findings, or is it a grade 2 finding, more serious findings, or is it suspicious for invasion? And then give your recommendation regarding the biopsy and regarding the diagnosis. So I think if you see this very carefully, you can see an aceto-white area, you can see some punctations, it seems to be quite dense aceto-white. So perhaps this is a high-grade lesion. And here again, we can see it on a higher magnification with some mosaics and punctations. So here again, in this lesion, once again, you talk about whether it is adequate, normal, the transformation zone type, what are the findings, the biopsy, and the diagnosis. So I think that if we go very, very carefully according to the IFCPC classification, keep it in front of you when you're doing the colposcopy, or keep a chart, or just keep a printout and circle what you are seeing, it will be much easier to compare. It will be much easier for us to do research and to do studies and to standardize and take better excisional specimens. So I think that I'd like to conclude now and say that the 2011 terminology helps with standardizations, and basically all colposcopists should be speaking the same language. And the grade 1 versus the grade 2 features help with differentiating high-grade squamous epithelial lesions with low-grade squamous epithelial lesions. And with that, I'd like to thank you for a patient hearing. And if there are any questions, I'm happy to answer.
So that's absolutely wonderful. And is our speaker, Saritha, is she ready? Or we can take up Dr. Sheila Mane's comments. Gitanjali, are you ready? Hello, Gitanjali? Jignesh, is Dr. Gitanjali there?
I think
Because
there's,
Yes, ma'am, she is
there's
there.
one question.
Yeah, there is a question in the chat box. The rich sign, one of the marker of sweet score, is it correct? And yeah, Gitanjali, will you be able to share your
Hello.
screen, or Jignesh is doing it for you?
I think Jignesh is doing it.
And
I've
Sarita, can
sent
you
in
just
the-
type your answers there so that, these questions can be addressed? Yeah, Gitanjali,
Yeah,
you can
sure, I'll
start
do
your
that.
talk. Yeah.
Yeah. Full screen can they do? Can you make it full screen, please?
Otherwise, you just start, no, Gitanjali, because
Yeah.
Jignesh, can you make it full
Yeah.
screen? Otherwise, you just show this. Right.
So I'm going to talk to you regarding the colposcopy interpretation. And Dr. Leela and Sarita has already spoken in detail about it. Maybe some of the slides of useful for you all. Can you pass on to the next slide, please?
ये भी तो हैंग हो रहा है पावर पॉइंट में मैम ये पावर पॉइंट्स इसमें कुछ इश्यूज है क्योंकि रन हैंग हो रही है मशीन
नहीं, आप इसमें मत करो ना, इसी को दिखाओ, इसी को चला लो, डोंट मेक इट फुल स्क्रीन इफ दैट्स द प्रॉब्लम.
ये दिख रहा है मैम?
हाँ, ये दिख रहा है. मेक इट इन दिस वे.
Yeah, I can go to the next slide, please. Essentials of colposcopy, as I've told you, the terminology using the right term. Okay. Next slide. Next slide. Next. Because it's already been.
This one, ma'am?
Next slide. Next. Yeah. See, little bit of tissue basis of cervix. The cervix has got an endocervix, which is lined by the columnar epithelium, which is a single layered cells with a basal nucleus, and underlying is the stromal vessels with the stromal connective tissue, which is thrown into many folds, as a result of which you get to see the villi and the crypts. This villi is always, usually it is vascularized with a stromal vessel, which is on colposcopy, it appears as a grape appearance or a sea anemone appearance. Next slide, please. This is going to be a problem.
I'm not able to hear any. Dr. Gitanjali, are you there?
मैम शी इज देयर बट उन्होंने शायद म्यूट कर दिया है वापस.
Gitanjali, you're not audible.
Hello.
Gitanjali,
Hello.
we lost you in the interim. I think from this slide or the previous one, we lost you. Unmute yourself, please. Jignesh, can you take the previous slide? Gitanjali, something is really problem, I think, with the technical. Again, you're muted. Why is it going every time into mute? Unmute yourself, please.
Yeah. Can you hear me now?
Yeah, we can. And go to the previous one. No, we lost you from there.
Yeah. Jignesh has to change. It is okay. This slide, it's a squamous epithelium is a multi-layered cells, as you all know. And the normal squamous epithelium with maturation of the basal layer eventually forms the superficial, intermediate and superficial cells. You can see the size of the nucleus from the basal to the superficial layer. The size of the nucleus goes on decreasing and the cytoplasm is increasing. So superficial cell layer and intermediate, the cytoplasm is with glycogen. This is the basis for the Schiller's test, as you all know. Next slide. Next slide. So this is in short about the process of squamous metaplasia. It is very important aspect of colposcopy, knowing the formation of squamous metaplasia. As you all know, when the endocervix columnar epithelium is exposed out into the acidic media in the vagina, it gets damaged because it is well cushioned in the endocervix in the alkaline media. So as a physiologically, what happens is that there will be a mechanism by which these cells there is a transformation of these injured columnar epithelium by the reserve cell hyperplasia, which occurs beneath the subcolumnar region. It grows over the columnar epithelium and it gets differentiated into immature squamous metaplasia and mature squamous metaplasia. You can see the mature squamous metaplasia, the different layer, they're highly differentiated, which cannot be differentiated from the other normal squamous epithelium. Next slide. So what are the things you see in the, as a result of the squamous metaplasia, the new squamocolumnar junction is being formed. So the transformation zone is a one, which is the original squamocolumnar junction, and the new squamocolumnar junction, which is formed due to a process of squamous metaplasia. In the transformation zone, what you get to see is the islands of columnar epithelium, duct openings, the crypt openings, Nabothian cysts, because these crypts get blocked because of the secretion getting inside and form follicle and the Nabothian cysts. These are the physiological things, what you see in the transformation zone, in the normal transformation zone. Next slide. Now coming to the principle, which has already been explained by Dr. Leela, the first thing what we application of the normal saline, which is very important aspect of colposcopy, wherein you demarcate the boundaries of transformation zone, inner limit, caudal, as well as the real limit of transformation zone, and the position of the squamous-columnar junction. And with the green filter, you can visualize the vascular pattern better. This has to be done under higher magnification. And in the next step is mainly the principal acetic acid test, where, as it is already been explained to you, depending on the density of the grade of the dysplasia, the density of the acetowhite lesion also increases. Next slide. Next slide. The next part, the colposcopy appearance of the normal cervix, squamous epithelium, which appear as in the transformation zone, it appears as a pale pink epithelium. In the exocervix, it appears as a pink epithelium, and the squamous-columnar junction, that is the junction between the squamous epithelium and this one, and the transformation zone I explained to you. Next slide. The columnar epithelium, the normal columnar epithelium, how does it appear? It appears as a glassy, grape-like thing. If you see it under higher magnification, with the red dots can be seen because it is the efferent and the efferent vessels which are within the columnar villi. This is the squamous-columnar junction. You can see it nicely, and the tips of the columnar villi, it appears white due to process of squamous metaplasia. Next slide. Next slide. In this slide, you can see the process of squamous metaplasia is certain. And this is the squamous metaplasia in the higher magnification, where you can see these villi, fusion of the villi, and you can see the sulca and diarrhea and the patchy areas of acetowhite lesion. This is a characteristic feature of squamous metaplasia. It's a different grades of squamous metaplasia can be seen. The differentiation of the squamous metaplastic lesion on colposcopy is very difficult in a tricky conditions like high-grade lesions. So you have to be very careful to differentiate the immature squamous metaplasia from the high-grade lesion, especially when it is associated with chronic cervicitis. Next slide, please. Next slide, please. Here, the process. Here, the squamous metaplasia is almost complete. It is the mature squamous metaplastic epithelium. The squamous-columnar junction is at the os. It is usually a finding seen in the perimenopausal age group. You can see the pale pink epithelium of mature squamous metaplasia, and the pinkish hue is different in this area. Next slide. Next slide. This is the new squamous-columnar junction. This in picture, the large ectropion bands of squamous epithelium, the types of 3 transformation zone, it is already been told to you. This is the type 1 transformation zone normal. In this, the squamous-columnar junction, it can be traced only by manipulation of the cervix. This is the type 2. Here, it is usually seen in the atrophic cervix, wherein the squamous-columnar junction is receded inside. Next slide. Next slide. This is the abnormal transformation zone. See, you can see the squamous-columnar junction, and the lesion is seen entirely. The previous slide, please. Previous slide, please. Previous slide. Yeah, in this, the lesion is seen entirely. This is a type 1 transformation zone. large lesion, squamous columnar junction with the lesion. This is a type 2 transformation zone. You cannot see the squamous columnar junction completely and the lesion is there, which is visualized by using the endocervical speculum, or you can use this plain dissecting forceps or the long artery forceps. The squamous columnar junction is nicely seen here and the lesion is also seen. In type 3 T-zone, the lesion is not seen, then the squamous columnar junction also receded high up and it is beyond our vision. This is a type 3 transformation zone, which is usually associated with the atrophic physiologically, otherwise in the high grade or early invasive lesions. Next slide. Next slide, please. The abnormalities on the one is abnormal acito-white lesion. It could be mild acito-white lesion or the dense acito-white lesion, and depending on the margins also has to be explained whether it is a patchy areas, regular margins, and regular margins. So these are the abnormal vascular pattern and the mosaicism and the punctations. Mosaic is usually formed by because the stromal capillaries get compressed by either by the immature squamous metaplasia or the dysplastic epithelium. It gets compressed, as a result of which you get to see the tiled appearance or the cobblestone appearance on the surface. There are fine which is usually seen in the immature squamous metaplasia or the again, yeah, I'm very sorry about it.
What happened, Gitanjali?
It just went off, madam. I do not know. Screen is.
But we can hear you. You continue.
But I cannot see the screen.
There is some connectivity problem, I think, in yours.
Punctations are usually formed due to it is the end-on view of the stromal capillaries getting compressed by the dysplastic epithelium. So end-on view on colposcopy, you get to see the dots. There are fine punctation as well as.
Kindly continue. Do you want to then okay, Gitanjali?
Yeah, this post punctations are usually findings of high-grade lesion or the early invasive cancerous lesions. So next, coming to the findings on invasive, the vascular pattern, what you see, normally the vessels, what you see on the colposcopy in the normal cervix, it is usually normal branching pattern, thick calibered vessels getting thinned out. Or in case of reparative phase, it is the parallel running thin calibered vessels you get to see. Or it could be a network pattern beneath.
Can change the slide, Jignesh. I think madam isn't able to see her this thing. So Gitanjali, we can do one thing. I'll take it up. I think there is a lot of interruptions from your side. I'll continue from here on, and you just be there and you can answer the questions whichever comes in the chat box, because now we can't waste our time, no? So dear friends, I take it up from here. That look at this normal vascular pattern. So the normal vascular pattern usually has a reticular pattern, and then you have a branching pattern, and you can see over here there is a large long vascular pattern. You usually see that on the Nabothian follicle. And then there is a fantastic one other pattern, which is called as parallel blood vessel pattern. Now, this parallel blood vessel pattern usually makes a person understand that this is a healing tissue. Like suppose if I would have done a LEDs and I would have called the patient, say after 6 months to see her relook colposcopy. And at that area, I find this parallel blood vessel pattern. That means I'm sure that this tissue is healing, or it is in the reparative or the reparative phase, or it is healed phase. Okay. Next slide, please. Now we come to abnormal blood vessel pattern. Now this abnormal or atypical blood vessel pattern. Okay, now you see these different types of patterns. Now they are not Greek and Latin, dear friends. We actually see them, and in a lesions. If you are seeing these, you are for sure that this is a very high grade lesion, might be a preclinical invasive CA. So now these are, different types of corkscrew type of patterns are there, waist thread type of patterns are there, and you can see comma type of pattern. Then you can see this hairpin bend pattern, which is widened. Now, dear friends, one thing I want to tell over here to you all is, whenever there has been a menopausal age group, okay, because of the atrophic epithelium, you would be able to see few patterns, and also those will be, those will be the normal pattern if the cervix is not under lesion. And again, in a cervicitis also, we would see enlarged vessels, but the pattern is very, very important. I like to go to the next slide. Now, the next slide comes up with colposcopic appearance of an inflamed, as what I just told you, on an infected cervix. So inflammation, desquamation, ulceration, and, you will see a lot of this papillomatous hyperplasia. And many a times, when you put a Lugol's, you will see a leopard skin patches. Going to the next slide, you will see colposcopic appearance of HPV infection. What she has shown over here? She has shown that there is a satellite. See, she has marked it with A and B. Now this A and B is showing satellite lesions. Usually you see them whenever there is satellite lesions are indication of flat condylomas due to low risk HPVs and all that. Okay. So now we go to the next slide. Now the next slide comes up with the colposcopic appearance of CIN. And how do you understand this? So as Dr. Leela was telling you, and as Dr. Sarita had told you about IFCPC, we all have been talking about aceto-white areas, color, surface, counter, and margins, and vascular patterns. So here you would see, look at the upper one. What has she shown over here? She has shown that there is an aceto-white area, and it has to come, the number one important feature for understanding the aceto-white important is it has to arise from the SCJ, all right, and within the transformation zone. Why should it come from an SCJ? Because one thing you understand, dear friends, SCJ is a dynamic epithelium. The HPV virus always comes up whenever it's an epitheliotropic virus. It requires dividing cells, and SCJ is a high dividing cell area, and hence watch out for an aceto-white area which is opaque. That's one thing which is very important. Coming to metaplasia, metaplasias are translucent. You would be able to see things below, this is translucent or transparent, whereas CIN lesions would be opaque. It will have a set geographical pattern, might be a low-grade lesion, might have a little feathery pattern, but doesn't matter. But it will definitely have a geographical pattern. It would be opaque. It would arise from SCJ within the transformation zone. And again, that area will be, iodine will not be taken up out there, and there can be variants of colors from saffron yellow to mustard yellow. Okay, now next slide, please. So the invasive CA, how does an invasive CA look on a colposcopy? So that's exactly what Madam has brought for you. See, whenever there is a growth, you don't have to have any colposcope. You are just one plain PS examination, do a biopsy, you know about it. But the preclinical invasive CAs are the ones which you will have to pick up. A colposcopist cannot miss out on that. Now, how does that look? There can be erosions, ulcerations, dense aceto-white. Here, it comes up with a chalky aceto-white. There can be coarse punctations, coarse mosaic. And another very important thing which has not been marked over here is whenever there is a breaking mosaics. Whenever there are those coarse mosaics and which are broken, they are indicative of definitely of a preclinical invasive CA. And you can see all type of patterns over here. Going to the next slide, please. Now, the next slide comes up is now interpretation. Normally, now Dr. Sarita has fantastically told about the IFCPC interpretation. And again, we would also have the sweet scoring, which was not there in this slide, unfortunately, but the sweet scoring comes up with the 5 pointers. You will have to look into the aceto whiteness 0, 1, and 2. 0 is set for having a thin or no aceto whiteness, or might be a translucent aceto whiteness. Then the next one, that number 1 becomes is when you have a milky white aceto whiteness, and the 2 comes up with whenever there is a dense opaque aceto whiteness. That is for aceto whiteness. Then the second pointer goes up is with the margins. Now, either there are no margins, okay, because if there is no aceto whiteness, might be just feathery or whatever. The number one pointer becomes in the margins is there is a clear-cut margin, but it is slightly feathery. And the second pointer, the second in the same pointer would be, second point is there is a raised margin. All right. So there is a difference between the level. So that is 2 given for the margins. Then comes up is your blood vessel pattern. So in this, fine punctations and mosaics, as I told you, the menopausal age groups does have many a time, because of the atrophic epithelium, you might find fine mosaics or punctations. So it doesn't matter, So in the vessel pattern, 0 goes for no pattern seen, or might be a fine mosaics. Now the number 1 becomes is whenever there is absent blood vessel. Remember, dear friends, HPV has, as was told by yesterday also, HPV has 3 types of phases, as was telling. One is the infection phase, where it's just on the surface. Second is an inflammatory phase, when the HPV goes into the episomal type of DNA, which is there within the cytoplasm, creating certain local inflammations. And that's the reason why you aren't able to see any blood vessel pattern. That's given number 1. Point number 1 for the third pointer, that is blood vessels. And in the 2 comes up your coarse mosaics and punctations. All right. So that becomes 3 points. Now the fourth point is your size. Now in size, the 0 will go for less than 5 mm. The number 1 pointer will go for 5 to 15 mm, or say more than 1. So 1 quadrant or more than 1 quadrant. Okay. And the last one is more than 15 mm, that is more than 2 quadrants. That goes for the 4th point. And the 5th point in the sweet scoring is talking about Schiller's test, that is iodine test. Here, number 0 is, of course, it's good. Mahogany brown, it's taken up, fantastic. Then number 1 score is given whenever there is any variegated patchy appearance on Lugol's. And number 2 score is given whenever there is a mustard yellow or, clear-cut yellow. So now you see, dear friends, whenever you have to have this type of interpretations, it's not only the colposcopy. You have to do the sweet scoring. You have to have an IFCPC, method of putting up your reporting system. The importance and relevance of a sweet scoring is the total score is 10. 0, 1 goes for atypical. 2, 3, 4 is low grade lesion, that is, CIN1, which we call as L-cell. Now, there were a lot of questions asking about grade 1 and grade 2, which we call as minor or major, or we can call it as an L-cell or an HSIL. So everything is actually the same. Then you have another understanding. Above 5 becomes HSIL. Okay. Above 5 is HSIL. That is, above 4 is HSIL. So your 5, 6, and 7 usually comes as CIN2, and 8, 9, 10 usually comes as CIN3. And nowadays, it's a 2-tier system where we call about minor changes or the major changes. Less than 4 of Swede is minor, and more than 4 from 5 on is major. And in a 2-tier system, you are supposed to say HSIL SIN2 or HSIL SIN3, but that's a histopathological understanding, not on your colposcopy. So why should you Swede it? Because if you want to screen and treat and all, you can actually understand. A very high grade lesions, please wait for the biopsy and the reporting. So I think that's the end of this talk. And since we are going little running short of time, we would be taking up now the remarks from Dr. Sheila Mane, as the Sheila Mane has left because of the thing. So Dr. Kiran Pandey has been there with us. Dr. Kiran, can you give the remarks for these 3 talks? I'm very, very sorry that we really had to have certain, hindrances in our deliberations. Is there Dr. Sheila Mane or Kiran Pandey?
Priya, Sheila Mane has left for some emergency.
So Dr. Lakshmi ji, will you want to close the remarks?
Kiran Pandey has also got some overlapping commitments. So let's finish our sessions, because I'm sure many of the things you will be answering in your panel discussion. So
there are many things to understand in the panel discussion. So now we go ahead.
Let's go ahead with our talks. Yeah.
Yes. All right. So now we go to the next talk, and with Debabrata Burman. And Debabrata is going to talk about ablative methods, because and who is Debabrata? Debabrata is a very known feature. He's a very excellent person with a professor, HOD, lot of knowledge in the Department of Gynae Oncology, Dr. B. Barua Cancer Institute, Guwahati. He is the person who actually did a lot of our app, SSNPP, and gave a fantastic feedback. Yesterday, we had seen his feedbacks, and this is the same Dr. Debabrata. Please, Dr. Debabrata, continue your talk on ablative methods.
Yes, ma'am. So can I share my screen?
Yes, please.
Yeah, you can, please. Go ahead.
Can you see my screen?
Yes.
Okay. Okay. So at the outset, I would like to thank Dr. Lakshmi Shikhande, Chairperson ICOG, Dr. Priya Ganesh, as usual, our dynamic secretary, and also Chairperson of our Gynae Oncology Committee of FOGSI, and convener of this fantastic online certificate program of Preventive Oncology for Cervical Cancer Screening and Elimination. So as you all know, basically what we are talking about is the story of the decay. So from this white patch, this woman will progress to this frank cancer, and that takes almost around a decade time. And it is during this time we need to detect them so that we can offer them a very good treatment in a very shortest possible time, which is almost 100% curable. So now during the last 2 days, lot of deliberations has been taking place regarding how to detect these CIN lesions, the via FIA, VILI, or D via colposcopy, VIM, pap smear, Ki67, HPV, P16. So all these things we have been discussing, and the final thing is that now ultimately once we detect this woman, we need to treat them. This goes back to that fantastic talk by Dr. Paul Blumenthal on the day 1 of this program, where he has one of the slides he has told, remember, screening and testing has no intrinsic preventive value. For a program to be effective, testing must be linked to treatment. So that there lies the importance of treatment. And I'm very thankful to the organizing committee for giving me this topic. So once you have detected this woman, you have to catch this woman. It is your responsibility and offer them the treatment. So if you see the FOGSI GCPR guideline, the thing is that they have told you can either screen and treat or see and treat as far as the ablative procedures are concerned. Now, let's come to the treatment part. So if you see the natural history of the cervical precancer lesion, the famous publication by Wester et al., which was published in 1993. Here, it's a pooled analysis of all the publications that has been published from 1950 to 1993. There, we have seen that if it is a CIN1 lesion, 57% will regress, persistence will be around 22%, progression to CS 11%, and progression to invasive cancer is only 1%. Whereas on the other hand, in CIN3, almost 12% will progress to invasive cancer as per this paper. So there lies the understanding that in CIN1, we can observe, and CIN3, we must treat, and CIN2, you have to decide case-to-case basis. So now, what are the principles of management? You have to optimize your treatment. You cannot over-treat at the same time, you cannot under-treat also. And once you have treated, you have to follow these patients either by cytology plus HPV at a particular time. And then once they are free of this disease, then you can push them back to the routine screening method. And you have to defer treatment in adolescent young girls or during pregnancy. So these are basic principles of management. Now, how do you select the patient? So you see, you have to select the patient based on the severity of the lesion. As I've already told, CIN3, you have to treat. CIN1, you can observe, but there are some CIN1 who will be having persistent CIN1, there you need to treat. And CIN2 also sometimes you have to treat. Then again, it is also based on the transformation zone. Fantastic talk has been given by my previous speakers regarding the concept of transformation zone. And if you really want to ablate this lesion, you have to have a very good type 1 transformation zone. Type 2 sometimes only when the lesion goes 1 to 2 mm inside the canal, then only you can treat. Lesion size is also very important. It is said if the lesion is more than 3/4 of the cervix, you should not treat because chances of failure is more there. Then again, the age of the patient, less than 25, we can wait. Parity, fertility status of the woman, the expertise and the equipments available. If you have the, if you are comfortable with LEEP, you do LEEP. But if you are comfortable with the cryotherapy, then you do cryotherapy. If you are comfortable with the cold coagulator, thermocoagulator, you can do that. So whatever equipment you have and you are expertise, that you have to treat. Thing is that you have to offer some form of treatment. Then if the patient gives a history of previous treatment with cryo, then next time again, what treatment you have to offer, that also you have to decide. Then again, you may find a patient who you are not sure whether they will come back to you if you don't treat them now and like to follow them up. Then in those cases, sometimes you have to treat those patients. And again, role of surrogate markers mainly in CIN2 lesions where you need to look for P16, EI67, and based on them, sometimes you would like to treat the CIN2 lesions also. So as I've already told, indications for treatment of LCL or CIN1, it is said that persistent LCL, CIN1 over more than 1 year, poor patient compliance, which I've already told, persistent infection with HPV 16 and 18, CIN1 preceded by HCL cytology and molecular markers P16, Ki67, PRO-XC, and HPV-L1 negative. In those patients, you would like to sometimes treat the CIN1 also. But in CIN2 and 3, all cases must be treated, but in CIN2, sometimes you can leave them also. There are some problems in the management of CIN1. It is said that reproducibility. When the slides were reviewed by a panel of pathologists, almost 41% were downgraded to normal and 13% were upgraded to CIN2 and 3. But then still, we need to treat them whenever we feel so. So now, what are the different treatment modalities? So there are two basic broad groups. One is the ablative technique, other one is the excision technique. Now, as far as I am concerned, I'll be talking on ablative technique, and the methods which we know as of now is the cold coagulation or the thermal coagulation, then cryotherapy, vaporization. So out of this, cryotherapy and cold coagulation is more widely used in all parts of the country or all parts of the world. So now, if you see the FOGSI GCPR chart number 12, there you can see where you can use your ablation. Sorry, you can use ablation. You can see you can use it in CIN1, you can use it in CIN2, 3, and also in screen and treat approach. In all those situations, you can use the ablative technique. So I'll just briefly discuss these 3 techniques. Now see, cryotherapy. What is cryotherapy? It is basically ablative technique for the ectocervical lesion. It uses freezing effects of refrigerants like nitrous oxide or carbon dioxide to produce tissue destruction, and it uses a cryoprobe with a tip made of highly conductive metal, usually silver and copper. What is the role of cryotherapy? If you see, treatment of CIN1 to 3, see and treat approach, treatment of chronic cervicitis and ectropion sometimes as a low-cost feasible technique, it can be used. And the eligibility criteria for choosing this patient is that the entire extent of the lesion is visible. It does not extend more than 2 to 3 mm into the endocervical canal, means transformation zone type 2. Clinical suspicion, oblique colposcopy and or biopsy should rule out invasive disease, and there should be no suggestion of glandular abnormality on cytology. Other things are that the entire lesion should be covered by the probe. Evidence of PID, cervicitis, vaginal trichomoniasis, or bacterial vaginosis should delay cryotherapy. If recently pregnant, she should be at least 3 months postpartum. Sometimes in postcoital, postmenopausal bleeding with unhealthy cervix should avoid treatment. Now, the factors influencing the success rate, if you see, it depends on the grade of the lesion, size of the lesion, visualization of the margin of the lesion, endocervical extension, adequate tissue destruction, and operator's experience. Now, if you want to select, I would like to select the lesion which is smaller in size, less than 3 quadrant. The lesion is limited to CIN1 or CIN2. The lesion is completely seen and the cryoprobe will cover it entirely. And the transformation zone and squamous junction are completely seen. This is mainly see and treat approach in the field. Suppose you come, it is done in your clinic, then maybe you want to see a ECC also sometimes. If the transformation zone has gone inside, it should be negative. No evidence of invasion or microinvasion on cytology, colposcopy, or biopsy. So what are the equipments that are needed to perform this test, treatment? You need the cryosurgical probe. Various sizes are there. Depending on the size of the lesion, you have to choose your probe. The gas tank containing the liquid refrigerants like nitrous oxide or carbon dioxide. You need a colposcope sometimes, and in the field you can do only with the naked eye also. Then casco speculum or ray speculum, wood light source, acetic acid, Lugol's iodine. So interaction of the cryoprobe with the cervix. This is very important. You know, the gas pressure, that is very important. Once you connect the gun with the cylinder, the gas pressure should be around 40 to 70 kg per centimeter square, which will be indicated by green in the meter, in the gauge. Then the size and the shape of the cryotherapy probe you have to choose. Anatomical position of the lesion of the cervix and shape of the os you have to see and determine. And see, you have to decide whether you are doing a single freeze or double freeze. So the procedure, you have explained everything to the patient, explained about the side effects that may occur or the complaints that may she have during the post-procedure period for the next 3 or 4 weeks. Then you have taken the consent, it is a privacy maintained, everything done, patient in lithotomy position. You have introduced the speculum, examined the cervix, and you have decided that now we want to treat. You have given the Lugol's iodine, you have given the acetic acid, Lugol's iodine, identified the lesion, chosen your cryotherapy probe, which you want to use, and then tip should be smeared with lignocaine jelly, and then firm contact of the cryoprobe and ectocervix should be maintained. Once you have achieved a firm contact, then you should start the machine, switch the machine on for 3 minutes, then switch it off for 5 minutes. And if you are doing a double freeze, again switch the machine on for 3 minutes and then switch it off. And then once it is thawed, you can take it out. You should see that the ice ball that is generated by the switching the machine on should extend 4 to 5 mm beyond the probe margin. And you should always maintain adequate pressure in the system. So this is how the cryo gun along with the probe with the gauze in it. You have switched the machine, everything is switched, everything is ready. You have examined, you have just put the speculum, you have seen the lesion, you are ready to apply your cryoprobe near the in the cervix, and then once you are there, switch the machine on. So once it is on, the timer should be there. Up to 3 minutes, we switch it on. And you can see a beautiful ice ball forming at the tip of the cryoprobe. So you just see, you wait. At the same time, you should see that it does not touch the lateral vaginal wall. Even sometimes you can use the condom if the lateral vaginal wall are less. So you can see, once it is switched off, after 3-4 minutes, you can take it out gently. So this is how it looks after the procedure. So now, sometimes it is said that one of the disadvantages of ablation technique is that you don't get a tissue for determining whether what type of whether it was any invasive lesion you have missed or not. So what you can do is that suppose you are doing you did the VIA, you got this acetophile, at the same time you can take a punch, and then once you have taken the tissue, then you can use the cryoprobe. A similar thing can be done with the cold coagulator, the thermocoagulator also. So see, just have taken the punch, and then now you can use your cryotherapy. So this is once you have done immediately, number 1 picture, and then here it shows after 15 days, after 3 months, and after 1 year. This is how the cervix looks like. So the post-treatment instruction is very important because these are the things you should tell to the patient before you do the procedure, because she may have all these complaints. And if you don't tell her before the procedure, she will keep on calling you. So what are the things? She may have watery discharge for 3 to 4 weeks, avoid vaginal intercourse for 3 to 4 weeks, or they can use condom, not to douse or use tampon for 3 to 4 weeks. Inform the symptoms of postoperative infection like fever, foul smelling, discharge, or pain lower abdomen. She should immediately report and come for a checkup. Now, once you've done the thing, how to clean the cryo. After use, the probe tip should be wiped with 60 to 90% ethyl or isopropyl alcohol, and then cleaned well with boiled water and disinfected with 2% literaldehyde and kept dry. The cryogon tube and pressure gauge and gas tank should be decontaminated by wiping the cotton soap with 60 to 90% ethyl or isopropyl alcohol. So, few important things. Cryotherapy cure rate by lesion size. I told you that if it is more than 3 quadrant, then the lesion, it is not that successful. It is based on these few RCTs where they have shown that once the lesion size is more than 75%, the cure rate drops down drastically. Then again, cure rate by endocervical canal involvement. There are RCTs where they have shown that if the endocervical canal is involved, the success rate goes down or the cure rate drops down. Then again, single freeze, double freeze. Here also we have RCTs done by Rogers and scans where they have shown double freeze has got a higher cure rate. So now this is again one meta-analysis of the effectiveness of cryotherapy in the treatment of cervical intraepithelial neoplasia, where it was a pooled data of around 28,000 cases of treated CIN were included in the meta-analysis. It is shown that cryotherapy achieved cure rate of 94% in CIN1, 92% in CIN2, and 85% in CIN3. Use of double freeze method and absence of endocervical involvement significantly increased cure rate. Minimal complications are reported as adverse effects. What are the complications? Early complications would be there may be some pain, which may be mild in 70% of the cases and severe in 5% of the cases. There may be fainting attack with nitrous oxide only, less than 2%. Postoperative infections may be there. Delayed complications like cervical stenosis in less than 1% of the patient, and reduced mucus production in 5 to 10% of the patient. What are the advantages and disadvantages? Advantages, they say that is effective with mild to moderate lesions, inexpensive, non-physician can perform, no local anesthesia needed, no electricity required, associated with few side effects and complications. The disadvantages are variable success rate with large and severe lesions, destruction leaves no tissue for sample. Then we can do that, definitely take care of this part. Difficult to determine exact amount of tissue destroyed and requires access to resupply of refrigerants. So now let us come to the cold coagulation. This is a treatment of cervical intraepithelial neoplasia and benign cervical lesion using a metallic probe heated to 100 to 120 degrees centigrade. Although it is called cold coagulation, it is a misnomer. But here basically heat is used, or it is now also called as thermocoagulation. So now heat is used at 100 or 110, 20 degrees centigrade. It leads to thermal destruction of the cervical tissue. Depth of destruction exceeds 4 mm after 30 seconds of treatment with cold coagulator. So these are the various types. This is the WISAP type. This is the old one, which was electrically operated, and almost 30 years back it has come, and now we have this handheld battery operated WISAP coagulator, and there is another one called the Liger. These are mostly used. So these Liger thermocoagulator, WISAP cold coagulator, and the MedGen thermal ablation system. All these 3 devices are there, which are CE marked and available in low resource settings. Although some newer devices has also come like cryoprobe and not, but these 2 are mostly used. So what is the equipment that is required for this cold coagulation? Either you use a WISAP or the Liger cold coagulator or thermocoagulator, whatever you tell. Metallic cervical probe is there, where for electrical connection, plus minus, it may be battery operated also. If you are doing in the field setting, no colposcope. If you are doing in a clinic, then it should be done under colposcope guidance. Cervical speculum to visualize the cervix, like good light source, and a couch. Now this you need cotton swab and S5% acetic acid and Lugol sardine, electricity or battery operated, whatever you want. The thing is same like the cryotherapy, but the thing is that this equipment is different. The other procedures are same: patient, lithotripsy question, service adequately exposed, everything done, colposcopy control, where colposcopy is available. Now, once you're done with this, set the cold coagulator at 100 degrees centigrade. Switch on the machine and let it attain 100 degrees centigrade. Once it attains 100 degrees centigrade, you had a beep and you are ready. Then you apply this cold coagulator, same like how we have used for the cryotherapy. At the gun, you apply firmly with the cervix, the area you want to treat, and switch the machine on. They say that around 20 seconds to 60 seconds, but ideally 45 seconds you apply and switch it on. If with your single application you cannot cover the whole area, then you can reapply in the other areas which are not being taken care of during the first setting. In this way, up to 5 overlapping can be done in the single patient in the same sitting. And more than 90% of the lesion will require 1 to 2 applications only. So how to sterilize this cold coagulator? First of all, you have to wash and clean the probe after use with cold water, wipe it dry and heat it for 45 seconds and 120 degrees centigrade. It is ready for use. But then but it is always advisable that you remove the probe and soak it in Sidex for 30 minutes, take it out, clean it with a warm saline or sterile water, and then dry it and use it for reuse. Side effects and complications are extremely rare, and more than 95% effectiveness in curing CIN lesions, and post-procedural instructions are same as cryotherapy. So these just few things. The Ligar machine, what is the cost of this machine? People may ask. So you'll see the Ligar or the WISUP and the Medgene. These are 3 systems which are available. And so the Ligar machine will cost you around $1,500. That means the whole system, along with the additional probes and all, 1.5 lakhs, I think, should be enough. There are rechargeable batteries for all the 3 systems. Then you have the post probe treatment temperature is 100 degrees centigrade for all of them. Probe heating time for the Ligar, it is 8 seconds. It takes 8 seconds to attain that 100 degrees centigrade, whereas in the WISUP, it takes 20 to 30 seconds. Treatment time, almost, it is nowhere, it is more than 60 seconds. It depends from 20 to 60 seconds. Ideally, 40 to 45 seconds is good enough. Then probe lifetime, in the Ligar, that one probe will run for 100 cycles. In the WISUP, it runs for almost 500 cycles. And method of infection, as I've already told, Sidex and also autoclaving can be done for the Ligar machine, and for the WISUP, only Sidex can be used. And for the Medgene, you use Cavi wipes or say Cavicide with enzymatic detergents. So there is this meta-analysis of the efficacy of cold coagulation as a treatment method for cervical intraepithelial neoplasia, systemic review, where they have concluded that the cure rates are comparable to those of other excisional and ablative methods. Cold coagulation is indicated for all rates of CIN. It is safe, quick, and acceptable, and may be of particular relevance for use in resource-limited settings. Again, this is a fantastic publication in the Lancet, where they have said that thermal ablation has similar treatment success to cryotherapy without the practical disadvantage of providing cryotherapy in an LMIC. Then carbon dioxide laser. Last 2-3 slides. What is that? Basically, we use laser to boil, steam, and explode the cells of the area where we want to treat. It is useful when CIN extends into the vaginal wall. Mostly it is used when in the vaginal wall lesion. So this is how the machine looks like, and mostly in the wall lesion, post-tectomized patients, sometimes we can do this, or if the lesion is extending to the wall fornices from the cervix. So this is the how it works. This is because of surface binding is there. This is how. This is also one of the ablation technique what we can do. So this is how. So there's the Cochrane review where they have compared all the methods that are available to treat the CIN lesion. They have seen that they have told that the evidence suggests that there is no obviously superior surgical technique in cervical intraepithelial lesion. The follow-up, I think there is a very good discussion on follow-up. So I won't take much time, 6 to 12 months or sometimes 24 months post-procedure followed by routine scanning. HPV can be combined with cytology during the follow-up. To conclude, treatment of CIN revolves around taking care of the transformation zones. Pre-invasive lesions should be managed according to their severity. Excision or ablation equally effective. Whatever you have to do. Thing is that you have to detect those women and bring them for treatment. Regular follow-up following treatment is the key answer to control cervical cancer. Thank you so much.
Fantastic, Devabrata. You have covered all the ablative methods and also showed a wonderful, video on CO2 lasers. That's the real up thing now in thing with all those this thing. Okay, so thank you very much.
Thank you, ma'am. Thank
yes,
you.
and now after this ablative, we are going now to excisional methods. So after Devabrata closes his
I'll
screen,
stop
I will.
sharing,
Yeah.
ma'am.
Thank you very much, Devabrata. You are always a genius and
Thank you.
you are an asset to my committee. Thank you very much. We have with us
Thank
Dr.
you, ma'am. Thank
Ashwini Valerao Gandhi, who has also joined us as a chair of these sessions. Welcome, Dr. Madam, Ashwini Madam. And we are now going to the excisional topic. Excisional method. So we have friends, we have seen ablative, now we are seeing excisional. And who else do we have? We have the right person for the right talk, Dr. Rupendra Shekhon. She is a senior consultant and chief gynae oncology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. And she's been the program director of DNBSS Gynecologic Oncology. She is a trained robotic console surgeon, gynae oncology from USA. And at present, she is holding the president post of AOGN. So I welcome you, Dr. Rupender, and over to you. You can share your screen. Dr. Rupender, are you there?
Yeah, I'm there.
Yeah. So Ashwini Madam, after this two talks, you will be giving your inputs and remarks about the talks which has taken place over time. Yeah. Okay.
So can you see me?
Dr. Rupender, have you shared?
Yeah, I'm just sharing. Just give me a minute. Yeah, can you see it now?
Fantastic. Yes. Go ahead.
Yeah.
On your slide sorter mode, so we see the full screen.
Yeah, I'll just put it on second.
Great.
And you have it. Sorry. Just give me a minute. So good evening, everyone. Thank you so much, Dr. Priya, for including me in this session. And all my talk and whatever else I had to say has been made so much easier by the excellent talk delivered by Dr. Devabrata. So I will straight away get to the topic of excisional methods. Whatever the indications are of ablative methods, we have absolutely the same indications for excisional methods. Only thing that the grade would be higher and the lesion would be larger. So that is the place of doing excisional methods. Yeah, 1 second. I think the screen is not moving. Is it moving? Hello, can you hear me?
We can hear you. It's not moving, but.
Okay, just give me a second.
It's moving now.
Okay, so let us talk. Is it moving now?
Yes, it was moving. Yeah.
Oh, I don't know why it's not moving again.
It is moving, Rupendra. Yeah, it is.
Okay, fine. So, like I said before, excisional techniques are basically for the management of high-grade lesions, that is CIN 2 or 3. The major advantage of excisional technique, of course, is that you have tissue available for histopathology. so that you can get an exact diagnosis, you can get an exact grade, and you can also know about the margins. So if you know about the margins, what happens is that any unsuspected microinvasion comes to light. More importantly, invasion is not missed. However, more technical skill is required than ablative procedures, and we therefore naturally need to do excisional procedures in a higher center, in a better center. Now, what exactly are these excisional procedures? Most commonly done is LEAP. You can have laser excision. You can have a straight needle excision. You can have a cold knife conization. And then, of course, ultimately, hysterectomy, which is very rarely indicated. Now, what are the types of excision? First we have the type 1 excision. Now, in type 1 excision, what happens is, as you can see very nicely, it is depicted over here, that you can see the whole of the transformation zone, right? And here, when you excise, you need not take more than 8 mm or so of the tissue. In type 2 excision, the transformation zone goes slightly above into the endocervical canal, and definitely you need to tailor your excision to something larger than 8 mm, and where you need to go into the endocervical canal so that the whole of the transformation zone is included. Now, type 3 excision, as you can see, the transformation zone is going right into the endocervical canal. You might not be able to see the top of the transformation zone. That is the whole of the transformation zone, and your excision has to be much larger and much greater. So this is where you might want to do a cone, or maybe a top hat if it is very going too much inside, or maybe a triangular cone or whatever else, depending upon the cervical length. So the classification of the excisional treatment, as has been put forward in a very nice paper by Prendeville and our very own Dr. Shankar Narayan, as you can see, depending on the type 1, type 2, and type 3. Now, it depends on the transformation zone type, which I have already told you, depending on whether the transformation zone is type 1, type 2, or type 3. Then condition, what is the grade of the lesion? Are we looking at a CIN1 disease, or are we looking at a CIN3 disease? Even if the whole transformation zone is of type 1, there also a type 1 excision will do. So it is very important to determine whether it is a CIN1, CIN2, or a CIN3, right? So you might not be able to see the transformation zone, even if it is a lower grade. However, you might be able to see the transformation zone, even if it is a higher grade. So you have to be very careful, do a colposcopic examination before you actually do the excisional treatment, mark out your transformation zone, and only after that determine what type of excision you are going to do. And of course, the types of excision already have named. You have the LEAP, you have the laser excision, and I mean all the 3 types of excisions, except of course type 1. In the case of type 1, are relevant for all zones. So please do not go away with the idea that because it is a CIN1, where by and large we just observe, but if it is a persistent CIN2 along with an HPV positive, where we think we need to do an excisional treatment, do not think that everywhere, because it is persistent or because it is a higher grade, so you have to do a high type of excision. You can have a high grade, low type of excision. You can have a low grade with a high type of excision. That is basically what I want to say. Now, what is the eligibility criteria for loop? Lesion extending into endocervical canal, distal limit not more than 1 centimeters, where there is no evidence of invasive cancer or glandular dysplasia, where there is no evidence of cervicitis, vaginitis, PID, bleeding disorder, anogenital ulcer. Then, of course, in the non-pregnant, wherein at least 3 months should have passed after her delivery. That is, at least 3 months postpartum. Contraindications, of course, are pregnancy and bleeding dyscrasias. Now, addressing each one of these procedures one by one, let's see what we have in the LEAP. We use a high power, that is 35 to 55 watt current. A thin wire loop, about 0.2 mm, is to be used, and so that there is minimal thermal damage. Monopolar blend current of 80-20 or 70-30 is used. Fulguration versus desiccation. Fulguration is definitely preferred. Now, one very important point over here. What we tend to do is we tend to position our loop at the cervix and then switch on the current. No, that is not what we have to do. So you position your loop just above the lesion, away from the cervix. Open the current, see that it is red hot, and then start doing your procedure. So actual cutting is the result of steam envelope developed at the interface between the wire loop and the water-laden tissues. So here you can see are the various instruments used. This is your Cusco speculum, along with something for the steam to go off. This is your tenaculum. You can as well use a valsalum as well, but tenaculum you can hold it from above, above the lesion, and you can hold the cervix steady. So many people prefer to use the tenaculum. Then this, of course, is the swab, and then the syringe. You need to put xylocaine there. This is the syringe, and these, of course, are the loops. And a very important part of the whole procedure is a ball cautery. And this is, of course, Monsell spaced in case you want to stop the bleeding. Insulated Cusco speculum are available, but even if they're not available, if you have even an ordinary speculum, you can put a glove over it. And of course, but a smoke evacuator is definitely a requirement. This is, of course, your cautery, which you have to have. We generally use Valley Lab, but there are any number of cauteries in the market, cautery machines, so you can use any of them. And these are the various sizes of the loops, small, big, depending on the size of the lesion. This is what you have to use. And this, of course, is the ball cautery. So this is a small video. I'll just show you. Is the video playing for all of you all?
Yeah, it's playing.
Okay. So as you all must have heard a number of times, the number of passes that we make, depending on the kind of lesion that there is, and whether it should be a vertical pass or a horizontal pass or whatever else. So there you see, this is what is termed as a horizontal pass. It's a small lesion, and you try to take away the whole lesion in one pass itself. And subsequently, you can apply Monsell's paste, or you can apply the ball cautery on it. And there you have the specimen. So this is just a pictorial diagram of the various types of passes, depending upon the type of lesion. But you have to be careful that you send each and every sample, each and every specimen which is taken out, you send it to the lab for analysis, so that no microinvasion or invasive lesion is missed. Because you see, only if the lesion is large will you take multiple passes. And it is in these large lesions that you might miss out an invasive component or even a microinvasive component. This, of course, again shows top hat and all that, which you must already be knowing about. If the lesion is, if the transformation zone is going into the endocervical canal, then this is the type of excision that you have to do. Once the excision is done, what many people prefer to do is, they will pin it to a cardboard box, or maybe to a cork or something like that, open it out, and to help the pathologist to show what is the length of the tissue taken out, what is the thickness, what is the endocervical margin, and what is the ectocervical margin. So it is important to help our pathologist to figure out what is all this about. Just taking out the specimen and then just sending it off might not be of great help. So this is again just to show you that you can do a straight wire excision. Basically, same thing is being done. You can even use a pointed needle, which comes along with loops and all, which can be more than 1 centimeter long. See, all of this is your personal preference, size of the lesion, and your experience, and how quick you are with all this. So this is just to show you what kind of specimens you can have and what is left behind after we have done the loop, the leap, and of course the lower specimens are, that is the cervix that is left behind after we do a cone. So now what are the indications of conization? High-grade lesions, suspicion of microinvasion, abnormal histology on endocervical curettage, discrepancy between cytology and colposcopy, and biopsy, especially high-grade cytology with low-grade histology. Then lesion extends into the endocervical canal and it is not possible to confirm the exact extent or if it is more than 1.5 centimeters, like I have said before. And cytological or histological evidence of atypical glandular cells or adenocarcinomas. And we have to remember that in the 6th point, it is important to do an endocervical curettage and even take an endometrial sample if possible. So now I'll just show you a small video of how exactly we do the cone biopsy. Okay, so here you are. This is the cervix. This is what we have done, used a Casco speculum, used a SIM speculum to retract the posterior vaginal wall as well as the anterior vaginal wall. And here somewhere is the lesion. You can't see it very clearly because of the shine. So what do? You take silk and 3 o'clock, 9 o'clock, 3 o'clock, 9 o'clock, 6 o'clock, and 12 o'clock, you tie off the cervical, the cervix. Okay, take a superficial suture which encompasses the transformation zone, the outer border of the transformation zone. See, that's clear? Okay, now before you do this, actually this slide should have been before that. What is it you do? You need to dilate the cervix. Okay? Because to do a cone, you must know the level of the internal os. So before you start the procedure, you need to dilate the cervix. And after you have dilated the cervix, you take these silk sutures at 3 o'clock, 9 o'clock, 6 o'clock, and 12 o'clock. This gives you a good grip of the lower border of the cone which you have to actually remove. So, yeah, so it is a large needle that they have given to us. You just have to make do whatever the OT staff gives. So basically, you just take those sutures like I have shown before. I'll just show you one. Yeah. So just take a simple stitch on all the 4 sides. Okay. So after this, then your cervix is now steady in your hands. Now, and you know where is the internal os. You know what is the length of your cone, approximate length of the cone that you need to take. Okay. Now you can start off your conization. So let me show you how we are doing it.
Monica,
just go around covering the transformation zone. All around the zone. So this is an absolutely unedited video. So the time taken is exactly what is being seen in the video. So after you have gone around it, around the whole of the cervix, then you start moving towards the internal os. So once again, with the dilator, confirm what is the length, cervical length till the internal os, and with gentle traction on the cervix, just go around. You will find that in this way the bleeding is minimal. The time taken to actually do the cone biopsy is minimal. And you have a nice cone that you can hand over to the pathologist. I hope you all can see the video. Can you see the video? So slowly and gradually making sure that the direction of your diathermy, the direction of your cotton is always pointing towards the internal os. And that you don't amputate the uterus as such. That is important. Because you need to leave some amount of cervical length behind definitely. So you can see we are using the needle. straight pointed needle, which is attached to the cotton easily. It requires a bit of expertise and to be able to make sure that you're actually taking out that cone. So here you take the help of your system. You should have a smoke evacuator. We have a suction attached. So the smoke is being evacuated with that. And you just remove off the cone. It's looking as if it's a very large chunk, but it's not really such a large chunk. It's just because, you know, it's magnified. And this. Almost so there you are. There it's done. Nice cone now. You see, and this cone is now already marked. Your 12 o'clock, 3 o'clock, 9 o'clock, whatever it is, you can leave the 12 o'clock thread behind and remove the rest. Now, after you have done the cone, now you can see you have adequate cervical length left. It's not as if, you know, we have amputated the cervix. Then what is the next thing you do? So with the ball cotton, coagulate all the bleeding points. And I always like to sound the cervix again, put in a dilator again to make sure that we haven't completely closed the os. So you can even, as you can see over here, you can even use a Alice forceps and you can use a Walslim as well. And then the cone is done. Make sure that you achieve complete hemostasis. When you're doing it, you can keep your coagulation at around 50 or 60. That helps. All the time, make sure that you do not coagulate or you do not use the current of the heat and the vaginal mucosa. So sometimes what happens, I'm especially showing you this, that the coagulation itself might not stop the bleeding and you might have to take a stitch on the inner surface. So you can use a 3-0 PDS or a 3-0 Vicryl and take a small suture there to stop the bleeding. See, if you remember previously what we used to do, we used to place termed off sutures and all when we are doing cone. That was basically to so that you turn in the mucosa. But these days we have such good diathermy instruments that we don't really need to do all of that. So there you are. So we have achieved a complete hemostasis. And one can even use a Monsel's paste even after this, but we are not really using the Monsel's paste too much. It should be fresh and it has to be obtained, and that is not always possible. Okay. Are you happy with it? So there you are. It's all done. So that is your specimen, and there it is, it's marked. Okay. Now, post excisional procedure care, routine antibiotics are given for 1 week. Generally, you can give doxycycline and metrogyl. Abstinence is advised for at least 4 weeks. Patient is advised to avoid douche or tampon for 4 to 6 weeks. You should inform the patient that a brownish black discharge will be there for a few days, that is up to 2 weeks, and that the patient should report if there is any foul smelling discharge or if that the discharge persists for more than 2 weeks, or that there is any form of bleeding, especially if it is excessive. Fever with pain or lower abdomen or with pain in the lower abdomen should also be reported. Now, prediction of success versus morbidity. It tells you about the margin status. It also tells you about the volume that is excised. It tells you about the TZ type. Preterm delivery risk depends on the length of excision. If it is less than 10 mm, that is less than 1 centimeters. So it is RR 1.32 versus 2.39. Outcomes of LEAP, recurrence of CIN 2 to 3 is 5.312%. Cold knife conization recurrences 1.43. So you can see that everywhere all the parameters have been compared, both of the LEAP as well as the conization. HPV clearance is almost the same in both the cases, whether it is LEAP or it is conization. You can see not much difference in that. Premature delivery rates are much lesser with the LEAP procedure than with the cone biopsy. So you have to apprise your patient about all of these. Obstetric outcomes, overall prematurity percentage treatment versus no treatment, it is 11.2% versus 5.5%. Preterm birth, that is birth at less than 37 weeks, is 10.7% versus 5.4%. And extreme prematurity, that is less than 28 to 30 weeks, is 1%. For other obstetric outcomes, overall prematurity is 11.2% versus 5.5%. Preterm birth at less than 37 weeks, I'm sorry, I'm just repeating this, 10.7% versus 5.4%. And large loop excision of transformation zone, RR is 1.5, 95% confidence interval. So for single visit approach, where you have to do an excision biopsy, it can be done where we are following the see and treat approach, provided there is colposcopy available. So it is advisable to do this kind of procedure only in colposcopic clinics where the patient has been referred with an abnormal cytology report, where colposcopic scoring indicates a high-grade lesion, where simultaneous treatment is done, that is excision or ablation, where there is low probability of overtreatment because of high specificity of cytology, and where post-hoc analysis of biopsy report versus excision specimen is there. So we see that all of this can only be done in a proper colposcopic clinic, and it cannot be done in your far out places. For all of this, the patient should be fully informed, and we should know that all the excision procedures should generally be avoided in the very young, that is in patients less than 25 years of age. Even if it is a high-grade lesion, you should avoid these excision procedures. Even if it is a CIN3, it is better to do a LEAP actually, rather than an excision procedure that is a cone biopsy, and then put the patient on observation and follow-up. Hysterectomy is considered too radical, however appropriate in the following conditions. Wherever there is microinvasion or CIN3 at the margins of a cone specimen, you can do a hysterectomy. Now, previously we used to wait for 6 weeks after doing a cone or 4 weeks after doing a cone to do the hysterectomy. However, these days, we have such good hemostatic techniques that you don't necessarily have to wait for so long. You can just give an antibiotic and just follow up the cone with a hysterectomy. Hysterectomy may also be done where there is poor compliance with follow-up in CIN3, and where other gynecological problems like fibroids, prolapse, and endometriosis are coexistent. So for follow-up, the duration and frequency of follow-up after treatment for CIN under the HPV test of cure protocol is here. You can access it from your IARC guidelines. I'll just say 1 or 2 of them. Women with a sample that has been reported as negative or as showing borderline changes or low-grade dyskaryosis and whose high-risk HPV test is negative should be recalled in 3 years, whatever their age. Where the 3-year test is negative, women older than 50 years can be called after 5 years. Now, women with a sample that has been reported as showing high-grade dyskaryosis should be referred for colposcopy. No high-risk HPV test is required before we do a colposcopy. Women who reach 65 years of age must still complete the protocol and otherwise comply with the national guidelines. And women in annual follow-up after treatment for CIN are eligible for the HPV test of cure at their next screening test unless that test is carried out at colposcopy. So the take-home messages would be colposcopic guided treatment is absolutely essential. You should define the threshold treatment after you have done a colposcopy. You should minimize excision of normal tissue. So be very careful and very sure to mark out your TZ zone. Be very careful and very sure what is the cervical length. In a postmenopausal woman where there is hardly any cervical length, you please do not try to do a cone. It is not possible. You will land up in trouble. In fact, in one of the cases that I saw, the uterus was so small and the cervix was absolutely flush with the vault. And we had this ambitious young gynecologist trying to do a cone, and we landed up with a huge hemorrhage because she has damaged the uterines. So please be very careful what you're doing. Take your time before you do these excisional procedures. They might look simple, but they really are not. You should make sure that you excise the whole TZ as one piece, minimize the procedure-related morbidities. Thank you so much for the patient here. And thank you for the
wonderful. Absolutely wonderful. Dr. Rupinder, complete justice given to the excisional methods, and your videos were very lucid. And now from here on, we move to the next talk, which is of Dr. Samar Gupte. Dr. Samar, are you there?
Yeah, he's there.
Yeah, I'm there.
Yeah, so just give me a second. So now the next talk is, like you have now seen, dear friends, ablative method, excisional methods. And now Dr. Samar, who is Homi Bhabha National Institute Fellowship in Gynae Oncology from Tata Memorial Hospital, Mumbai, and has been trained in onco-surgeries at Tata Memorial for 5 years and trained at UCLH London and Milton Keynes General Hospital, UK. And he is fantastic surgeon. I know him very well. So now Dr. Samar will be taking us through treatment of preclinical invasive, early invasive CA as well as advanced cancer. Over to you, Samar.
Yeah, thank you, madam. Thank you so much for a fine introduction. And what a fantastic 2-3 days this has been. I mean, Dr. Sekhon's last talk was just absolutely mind-blowing. I'm going to share my screen now, and hopefully there should be no glitches here. So let me see, share. Can people see the whole screen where I've written preclinical invasive cervical cancer?
Yeah, Samar, carry on.
So I've got quite a large mandate to cover here, but basically what I'm going to cover is preclinical invasive cancer. That means you really can't see a lesion, but it's invasive. And so by definition, it means a very, very early cervical cancer. And then at the end, I'll say a few words about, the later stages of advanced cervical cancer also. So this is this wonderful staging that we've got in 2018. I've picked it up straight from Dr. Bartla's paper. So, I mean, there's nothing original about that. It's madam's own work here. I'm going to be focusing on the top half of it, which is where the carcinoma is strictly confined to the cervix and it's microscopic, where the maximum depth of invasion is less than 5 millimeters, 1A1 being less than 3 millimeters in depth and 1A2 being between 3 and 5 millimeters in depth. To some extent, one can even add a little bit of 1B1, where the depth of invasion may be more than 5 millimeters, maybe 8-9 millimeters, which we can't see by the naked eye, but it's still there microscopically. So before I begin, let me just first say that, prognostically speaking, cervical cancer depends upon the volume of tumor, which is obviously a 1A1 tumor will do much better than a 1B3 tumor. It depends upon the histological subtype and grade. Most of our cancers are squamous cell, then adeno, and the rest of them. Now, I just want to state that when I'm talking about cervical cancer, microinvasive, or the early stages, most of the work that has been done on the good old squamous cell carcinoma. Having a 1A2 tumor, which is a clear cell carcinoma, well, it's really difficult to figure out whether we can be conservative or not, and those are still gray zones. A lot depends upon the lymphovascular space invasion, because when it comes to oncology and oncosurgery, we more or less believe that when there is LVSI, there is a good chance that some micromets have happened in the lymph nodes, and lymph nodal mets, the surrogate marker for systemic spread, and so on and so forth. So LVSI is a very, very big concept in tumor histology and tumor biology or tumor histopathology. So let me dwell straight right into it. So when you're talking about management of stage 1A cervical cancer, let's see, most of these are preclinical lesions detected by cytology, colposcopy. Management also depends upon age, comorbidities, fertility concern, and there is no set treatment, but it needs to be kind of discussed with the patient, and obviously a follow-up is emphasized. So let's see, most of our patients who come to us do not come to us with a 1A1 or a 1A2 lesions. They've had an HCIL done, or they've had a pap smear done, whether it's HCIL, LCIL, ASCUS, or any of these things, and then they undergo a LEAP, LEDS, or a wonderful cone, as madam has just demonstrated some time back. And then the histopath report says microinvasive carcinoma of the cervix, 1A1 or a 1A2. That's where these patients come to us. And now we have to figure out, what do we do with them next? Is this treatment adequate? Is it not adequate? Then everything comes on. So majority of our patients come at this point. There is a very small group of patients who actually have a pap smear that shows squamous carcinoma cells, but no clinically seen lesion. And then you can actually prospectively plan some sort of treatment for them in times of, cone biopsy, trachelectomy, hysterectomy, whatever may be the case of that. So majority of our patients actually present with a surgery done, like a LEAP, LEDS, or a cone, and that inadvertently shows us a microinvasive cancer. So let's assume a patient comes to my clinic and she says, oh, I had an ASCUS H on pap smear. I went to my doctor. They did a LEAP procedure, or they did a cone biopsy. And this is my report. And the histopath report suggests a 1A1, a microinvasive cancer less than 3 millimeters depth. The margins are clear and there is no LVSI, in which case I will deem that the treatment is complete and this patient requires no further treatment. So this is what our guidelines tell us. She goes on to a regular follow-up, and if she's young and desirous of children, obviously she can go ahead with a fertility treatment or whatever she wants to do. However, if her family is complete, then it is just a recommendation that because we've diagnosed it as a microinvasive carcinoma and the word cancer is there, it would be a good idea to propose that this woman has a hysterectomy with a bilateral salpingectomy. Or that is, the oophorectomy part is obviously optional and something that you need to discuss with her based on her age. But it is always recommended that in these cases, let's do a good frozen section, because it's just so maybe that there is this focus of cancer somewhere, in the cervical stroma. So the treatment of 1A1 is pretty much, straightforward and very regulated. Having said that, I must say that, in our clinical scenario, it is not common to get 1A1 and 1A2 tumors. I mean, more often than not, we get 1B and greater tumors. So I think these are situations which happen once in a while that you see come across 1A1 and 1A2 tumors. One tip that I had learned some time back is, if I'm going to do a hysterectomy for a 1A1 tumor, you do the hysterectomy the way you want to, laparoscopically, the way you want to, but it would be a good idea to actually transpose the ovaries in the lumbar region outside the pelvis, because just an offside chance that your final HPR actually demonstrates a larger area of cancer, and then you have to follow up with radiation. At least your ovaries would be sort of, saved from the radiation damage. So let's look at it. Let's look at now let's look at the next scenario where the patient walks into my clinic. A cone biopsy or a LEAP has been done. The histopath report says it's 1A1, but with LVSI positive, that is lymphovascular space invasion positive. Now, I'm not talking about margins positive, because if you've done a cone biopsy or a LEAP and the margins are positive, then obviously it's more than a 1A2. It moves on to the realm of a 1B1 tumor, and then the treatment is completely different. So let's look at the microinvasive scenario here, where it's a 1A1, the margins are clear, but LVSI is positive. Again, before I go on to treatment of these kind of tumors, let me just state that 1A1 with LVSI positive is an even rarer situation that you will ever encounter, because by definition, it means that the pathologist may not have seen all areas of that cone or that LEAP specimen very properly. It is very difficult just to have a 3 millimeter depth of invasion with lymphovascular space invasion also. But let's assume theoretically that it's a 1A1 with LVSI positive. Then there's one option. If the patient is older, desires no fertility, then obviously one can go ahead, because it's a cancer, one can go ahead and do a type 2 radical hysterectomy with a lymphadenectomy. However, it's a microinvasive disease, and doing a good type 1 hysterectomy with lymphadenectomy or sentinel lymph node sampling is also a good option. And in fact, it would be the preferred option in most of these patients. And therefore, I've highlighted that in yellow. Again, I'm talking here about low risk cases. Low risk could be squamous cell cancer, or those which are well differentiated, not something which is poorly differentiated, or clear cell cancer or a neuroendocrine tumor of the cervix. We're not talking about those things at all. So the next scenario obviously is for a younger woman who desires fertility. She's just had a cone done. It's 1A1 with LVSI positive. What can we offer her? Now this is when things get a little murky and gray. The books will tell you offer them a radical trachelectomy with lymphadenectomy, or at least with sentinel lymph node. The other option is also doing a conization, with lymph node. So she's already had a cone biopsy and come to me. So my question now is, she's had a cone biopsy, she's come to me, margins are clear, it's 1A1, but the LVSI is positive. So do I really need to sample the lymph nodes in this patient? Do I need to do something different for these patients? What do I do for these patients? So obviously the best thing here is, first I would do an MRI or a PET scan and see that I'm not really missing out on something else. After which, it is highly recommended that the lymph nodes are sampled in one way or the other. So I will have to take this patient under anesthesia. I will have to either do sentinel lymph node biopsy if I have the equipment, or go ahead and put in a scope and do a lymphadenectomy of the pelvis. And then it stands to do good practice to actually, revise the cone and do a good conization again, if not already done, and then send all that for histopathology. Now, so in cases of 1A1, this would be the preferred option rather than doing a radical trachelectomy. Again, these are just very broad guidelines that we've picked up from the American College or from, a lot of papers that have been written. So in a 1A1 tumor where the patient wants to conserve fertility, I think that, a good conization with lymph node sampling or lymphadenectomy would be a good option, provided your MRI and PET is clear. If I move on to 1A2, now remember the difference between a 1A1 and 1A2 is very small. It's just 2 millimeters more space occupied by carcinoma cells. So again, here the issues are the same. Fertility desired versus fertility is not an issue. Again, when fertility is desired, and I'll show this chart again, a cone biopsy with bilateral pelvic lymphadenectomy is a good option, or even a radical trachelectomy with bilateral pelvic lymphadenectomy is a good option. If the fertility is not an issue, then obviously you go on to your type 2 radical hysterectomies or even brachytherapy. So I go back to my original slide that I showed, but this time I'm labeling it as a 1A2. So let's say the patient desires no fertility or is a little older. What would we do? Again, the options are the same: a lymphadenectomy with a type 2 radical hysterectomy, or a simple type 1 hysterectomy with sentinel lymph node, that sort of a thing. Here I've highlighted a type 2 radical hysterectomy in yellow, because for a 1A2 tumor, very often it's a better option to kind of do a type 2 radical hysterectomy. It might be an overkill, but if it always turns out to be a better option. Again here, if the patient is LVSI positive on your original cone, then I would definitely think of doing a type 2 radical hysterectomy for this patient. Let's say the same patient has a 1A2 lesion and desires fertility. Then again, I have the same two options. Whether do I offer her a trachelectomy with lymph node with lymphadenectomy, or do I offer a conization with lymphadenectomy? So because it's 1A2 and the incidence of lymph node metastasis is slightly higher, and the chance of LVSI positive also being slightly higher, it would be a great idea to actually do a trachelectomy in this patient and not just leave it at the cone. So there's a subtle difference between a 1A1 and a 1A2. Again, this is only if you're kind of nitpicking into the details, but more often than not, very practically, what I've come across is 1A1 and 1A2 lesions are rare. 1A1 and 1A2 with LVSI positive is even rarer. And the fact that such young women come for desire for fertility, I mean, that's a very, very small subset of patients we're looking into. So I think it's all got to do with a detailed discussion with them, and then doing what you think, or what the patient and you as a doctor think what's best for the patient. So in short, if it's a non-visible lesion, you do a cone biopsy. It's stage 1A1, as we said, then the incidence of lymph node mets is 0.5%. A good conization if fertility is desired, or a class 1 hysterectomy if fertility is not desired. If it's a 1A2 lesion, then the incidence of lymph node mets a little higher, 5 to 8%. And for these patients, type 2 radical hysterectomy or a trachelectomy with a BPL-ND is, broadly speaking, this is where we stand for these patients. I know I don't have much time left, but I'll just run through the other stages of cervical cancer. What does one do for stage 1B cervical cancer? Well, again, It depends on age, medical comorbidities, desire for fertilities, and all the other things that I mentioned there. But it is very evident that hybrid therapy, that is surgery plus adjuvant radiation therapy, is associated with serious morbidity. There is no treatment of choice for these early stage cervical cancers. Treatment has to be individualized depending upon the pros and cons of surgery versus radiation. Generally speaking, in stage 1B, one would err on the side of caution, or one would err, I wouldn't say err, one would move towards doing surgery for these patients and doing a good, what we used to call in the past a Wertheim's hysterectomy, and today a type 2 or a type 3 radical hysterectomy, which is more or less the type 3 radical hysterectomy with a lymphadenectomy is the standard of care. Ovarian preservation is possible in young patients. The advantage of primary surgery is it allows for preservation of ovarian functions, allows for ovarian transposition, sexual function can be preserved, detection of other pathologies, and it helps you to identify those high-risk patients who would benefit from adjuvant therapy. Again, advantage of primary surgery, complication rates are lower, experienced hands, psychological benefits for the patient that the tumor is out, and some of the complications that one sees with radiotherapy, like bladder and bowel complications, they're not there here. Then again, I must mention that radiation therapy has its own benefits, because radiation therapy, that's concurrent chemoradiation, is a standalone treatment in cervical cancer. You do not need to combine it with anything else. It's a one-stop treatment, no anesthesia, no surgery. So pros and cons of everything that need to be discussed with the patient, and then one takes their call. Broadly speaking, stage 1B1, as we discussed right now, it could be radical surgery or it could be concurrent chemoradiation. You take a call based on what you think is right with the patient. 1B2 and 3 also, you have the same approaches, though for 1B3, I would say concurrent chemoradiation does play a slightly better role. Most of the patients in whom you're going to operate on a 1B3 tumor are going to require radiation later on. And as we discussed, a dual modality approach is not the best when it comes to morbidity. If you've done a good surgery, then obviously, depending upon what you find on the histopathology, patient might need concurrent chemoradiation or might need just radiation. So this is, I've just highlighted there in this slide here. There's another concept that was pretty prevalent some time back, where there's a large bulky tumor, which we call 1B3 today, where there was a thought process that one could give neoadjuvant chemotherapy, downstage the disease, and then go ahead with surgery. Well, there were a lot of papers, a lot of trials that were conducted. It did show benefit initially, but we have our own Tata Memorial Hospital big trial that actually showed that there was no great advantage of doing NACT followed by surgery. A concurrent chemoradiation was good enough to take care of these tumors. We talked about fertility preservation earlier when I talked about 1A2, but to go into detail about radical trachelectomy, it's a procedure for fertility preservation for 1A2 to 1B1 tumors. Resection of the diseased cervix with a vaginal cuff is the procedure. The uterus is transected at the isthmus and sutured back to the vaginal vault. It's a very difficult surgery, not very commonly done. Not many of us have great experience or haven't been exposed to that many of these procedures in the past. But of course, bilateral lymphadenectomy is an integral part of these procedures. Young women desirous of fertility, tumor less than 2 centimeters, commerce carcinoma. These are some of the strict criteria that one has to follow while selecting a patient for radical trachelectomy. So this is just for those who are interested. Again, this is not my work. I've picked this up from a friend of mine who's done it many years back. The descending cervical arteries are tied off, and the cervix is sort of excised, and the uterus is sutured to the vagina. Remember, lymphadenectomy is a must. And it's always recommended to do a lymphadenectomy first and do a frozen section. If your lymph nodes are positive, then there is no role of radical trachelectomy in that patient or in that subgroup of patients. When you go on to an advanced stage cancers like stage 2B, stage 3A, and stage 3B, obviously concurrent chemoradiation is the treatment of choice. For 4A and 4B, also concurrent chemoradiation is the treatment of choice. Sometimes we come across tumors that have invaded the bladder or the rectum in stage 4. In these patients, there's a common belief that if you give radiation upfront, it will form a fistula. Very often we give them chemotherapy to shrink the tumors first and then follow it up with concurrent chemoradiation. Surgeries like exentration or LEER are more or less left for recurrent central recurrences. rather than doing it as a straight off treatment for these tumors. And these are just some photographs of how external beam radiotherapy is planned for a lot of these patients. These are some of the photographs of where one does panning for vaginal brachytherapy or intracavitary or interstitial radiation therapy. And so I'll just end my talk here by saying that, all these are very drastic therapies and treatments. The best option is to screen and catch cervical cancer early and get it treated. So I just don't want to run over time. I think, madam, that's all. I'll stop here and try to finish everything in time.
Lovely, Dr. Samar. You have always been fantastic, and I have always loved to hear you. So you have done on time as well. Thank you very much, Samar. And after hearing from all the stalwarts, now we go for follow-up. So the time is now to understand. We have done all the treatment. How do you do the follow-up in the post-treatment? And do we have Dr. Sangeeta Pankaj with us?
Priya, by the time the next speaker is getting ready, there are 2 questions which I saw. I think, Samar, you can answer them.
Yes, madam.
He can type it, madam. He can type it there.
Okay.
Samar, so that we take
about
this.
CA ovary and CA cervix, whether in CA ovary patient.
Samar, will you please take it up and type it from there? I think Debabrata is also doing it. But Samar, you also please do. So now I will share the screen of Dr. Sangeeta. I'll just introduce you all to Dr. Sangeeta. Just a minute. Let me put up. Yeah. So Dr. Sangeeta is Professor Gynecological Oncology, State Cancer Institute, IGIMS Patna. She is working as professor and HOD in the Gynecological Oncology, State Cancer Institute, and chairperson of POGS Oncology Committee. She has been having this post since long time. You can see right from 2019 to 2023, and winner of FOGSI Dr. C.S. Dawn Prize, and she has a lot to her credits. We would like to hear from you, Dr. Sangeeta, regarding the post-treatment the follow-up of post-treatment. Thank you very much. Kindly go ahead, sharing your slide.
A very good evening. Thank you, Dr. Priya, madam. It is my privilege to be a part of this program. And after hearing 2 such learned speakers, it was really very good time. And now it is my turn. The topic given to me is post-treatment follow-up. So are my slides visible? Hello?
Yes.
So it is
only put them on the whole single screen.
Pardon? Is my screen visible?
Yeah, the screen is visible, but you have to put the slide on the full screen.
Yeah, it is on full screen.
No, we can see the other slides also.
Now, is it okay? Hello?
You can go on. If you can't do it, it's okay. We can see the main slide also.
Okay. So it is an international practice for many of the diseases that we have to do follow-up and treatment. And the same is true for CIN and cervical cancer also. And it will depend on the availability of clinical, laboratory and nursing staff, as well as the cost to the patient for attendance for follow-up, and that will influence what all arrangements the patient goes to which setup. So because there is patient's risk of progression to cancer is related in large part to their age and CIN grades, ACCP guidelines have considered these two factors in deciding the aggressiveness required in management of the disease. So to understand the disease course and risk progression, first we need to understand the natural history of CIN lesions. And this will help the clinicians in counseling the patient when simple observation is required, when aggression is the management. So among the patients with persistent CIN1 at 6 months, they have to follow for 12 months, 50% will regress to negative, 46% will have low-grade lesions, and few will have high-grade lesions. And it was the same was evidence for CIN2. It appears that at least half of the patient will regress if they are left untreated. And in a meta-analysis of 36 studies, there were 3160 participants with CIN2, and the same thing was noted. For CIN3, the estimated spontaneous regression rate is 32 to 47%, and 12 to 40% will progress to invasive cancer if they are left untreated. And the cumulative incidence of invasive cancer for cervical vaginal vault was significantly higher in patients who were left untreated at 10 years and 30 years. So a lot has been shown how HPV infection progresses to HSIL and then to cancer. So this was a study which showed that the long-term risk of cervical cancer following conization of cervical intraepithelial neoplasia grade 3, Danish national-wide cohort study.
Dr. Sangeeta, I'm sorry to interrupt you, but the slides are not moving. I think you have to put them on the full screen and then you have to forward them. The first slide only is there.
Okay. Is this slide visible?
7 number slide at present we are seeing.
So is it now full screen?
No, it is not full screen.
I'm making it full screen. Why?
Can you move it to 8 number slide? Because they were not moving in between. If you put full screen, they will start moving.
Yeah, this I'm making it full screen.
Can you go to 8 slide now? Let us see whether they are moving.
Yeah.
In slideshow, you have to go in the full screen then. Which slide you are talking about now? 7 number or 8 number?
It is 7.
Okay, so can you go on 8? Let us see whether 8 is coming or not. Yeah, so you do it same way now. You will have to go to each slide and make it 8, 9 like that, because otherwise it is not moving.
Okay.
Please carry on. You can carry on.
Okay. So in this study, the women diagnosed with CIN3, now is it moving? You can see.
It is on the 7 number slide. Yeah.
So women diagnosed with CIN3 on cone biopsy, they had long-lasting increased risk of cervical cancer even when the margins on the cone were negative. So this is very important that when we think that out of these patients, the patients who were negative, they also progressed over long term. When it was follow-up, even the negative margins progressed to invasive disease. So it is very important, either it is positive or negative, we have to keep the patients on follow-up. So it is very important for this. And the risk of recurrence is influenced by margin status of cone. And the absolute risk of incident of cervical cancer in relation to follow-up time for all women with CIN3 on these patients were 59,464, women with negative margins 27,000, and women with positive margins were 7,699, and we can see their progression. So hence HSIL lesions warrant close follow-up for long term. And the goal of follow-up in post-treatment patients is to prevent possible progression to cancer while avoiding overtreatment, since lesions can spontaneously regress and treatment can have morbid effects. In post-treatment phase, either the disease will be cured or they may have persistent or residual disease. And the residual disease is the detection of histopathological HSIL, CIN2, 3, or AIS diagnosed from punch biopsy or any surgical specimen at any time interval, and there is no intervening document of absence of the disease. Means it is persistent, it has not gone. But in recurrent disease, it is defined as detection of histopathological high-grade lesion, again from the biopsy or any surgical specimen, following documentation of absence of high-grade lesions. So the disease was absent during this period at any time interval and it came again. So this is recurrent disease. The patients may have non-specific symptoms and consequences of presence of disease in post-treatment follow-up. The patient may need retreatment for high-grade lesion. They may have adverse psychological effects. There are resource implications, including cost, human resources, and hospital services. And this is addressed by use of different assessment protocols and follow-up, which we will discuss. So the protocol first aid. The comprehensive post-treatment surveillance includes testing. And it has been reported that persistent HPV infection after the treatment is likely to is the key factor for relapse of CIN and cervical cancer. Therefore, it is crucial to evaluate HPV infection status in follow-up period. Physical examination is simple and inexpensive, but the microscopic lesions cannot be found. Cytology is widely used for post-treatment surveillance in clinics, and the rationale for HPV DNA testing in follow-up of patient relies primarily on its high specificity, sensitivity, and negative predictive value, which will be enormously reduce the burden of follow-up visits. So what are the WHO recommendations? The WHO recommendations for follow-up tests at 12 months post-treatment for general population of women if she has been treated without histopathology. Results are available, or if based on histopathology CIN2, 3 or AIS is there, then she has to be followed up at 12 months. If the results are negative, then she has to go back to routine screening interval dependent on primary screening test. If the results are positive, it has to be retreated. Patient has to be retreated with less. And if the results are positive and there is suspicion of cancer, she has to be referred for evaluation biopsy and further management. And post-treatment follow-up for test, she has to go for post-treatment follow-up and test with 12 months.
Hello. So hello, can you hear me?
Yes, yes.
Yes, ma'am.
Yeah, so fantastic. And now we want to hear from Ashwini madam. Few slides are remaining. Are you?
Yeah. So okay. In WHO, for women, the follow-up test with post-treatment with women living with and it is negative, the same protocol has to be followed. And in ASCO, there are some ACCP guidelines. In 2019, the fourth ACCP sponsored consensus guideline came into management for cervical cancer screening after original consensus, which the first was in 2001, then 2006 and 2012. The key difference between 19 guidelines and the previous one is that the change from primary test results based algorithm to colposcopy. Example, colposcopy is recommended for patients with HIV positive patients as plus LSIL to primary risk-based guidelines. And the other differences were colposcopy can be deferred for certain patients. Guidance for expedited treatment is expanded. That is, colposcopy can be done without treatment can be done without colposcopic biopsy. Observation is preferred for CIN1 lesions, and histopathology reports for lower anogenital squamous terminology, and WHO recommendation for reporting HSIL should include CIN2, 3 lesions, and all positive primary HPV screening tests, regardless of genotyping, should have reflex trials. Means if the report, the cytology should, if one report is positive, the other has to be done reflexly, and continued surveillance with HPV testing at 3-year interval for at least 25 years recommended after treatment. And surveillance with cytology alone is acceptable if only testing with HPV or co-testing is not feasible. And high-risk HPV assays approved by FDA have to be done for management. Management will be based on patients with risk of CIN3 plus. The 2019 guidelines make this recommendation based on immediate CIN3 plus risk or 5 years CIN3 plus risk. This is calculated. This figure demonstrates how patient risk is evaluated for current status and history, the combination of immediate CIN3 risk. If it is greater than 4 or immediate treatment by colposcopy, and if the immediate risk is less than 4, the 5 year CIN3 risk is examined to determine whether patient should return at 1, 3 or 5 years. So this shows that the HPV plus NILM, it has less than 4% risk. ASCUS has more, and all these have more. And why the why 4% estimated risk of CIN is necessary? The clinical action of threshold of 4% of immediate risk of CIN was considered as reasonable benefit and harms, and validation of threshold included as KMPC, NMHPV registry, CDC breast and cervical cancer early detection program, BD on clarity trials, etc. And the 4% threshold functioned similarly, and examined clusters patient in different result groups, high grade results, low grade results, and combinations. And in previous conferences, working groups were considered specific outcomes as ASCUS, HPV positive, and special populations. In contrast, the 7 working groups for 2019 guidelines were organized with goal of establishing consensus clinical action thresholds. These were treatment group, colposcopy group, surveillance group, and those group and in surveillance, those with minimum screening results not requiring colposcopy or after treatment of high grade abnormality, the risk modification group, the high value care group, the new technology group, and the communication groups. Generally, there are 2 approaches. Either we have to do close observation with HPV testing or co-testing, cervical cytology, and colposcopy, and treatment with excision or ablation of cervical transformation zones. Follow-up treatment of histologic HI-Sil in patient has to be done for more than 25 years. Either HPV testing or co-testing is preferred, and surveillance with cervical cytology alone is acceptable only if testing with HPV co-testing is not feasible. So cytology is less sensitive than HPV or co-testing, hence more frequently it has to be performed to achieve similar sensitivity for detection of CIN3+. For example, in a case of low-grade cytology followed by colposcopy less than CIN2, follow-up and if the follow-up test is an HPV test with negative results, the 5 year CIN3 risk is 0.51% and it is consistent with 3-year return. However, if follow-up is of the test cytology, it gives only negative results, the 5 year CIN3 plus risk will be only 1.5% with 1-year return. So cytology will be recommended at 6 months interval when 1-year interval is recommended for HPV or co-testing, and annually when 3-year intervals are recommended for HPV or co-testing. And cytology should be used for 5 years with transition to HPV-based testing at 25 years or older. And for CIN2-3 lesions, observation is acceptable for CIN2 in patient concerned about potential effects of treatment on future pregnancy outcomes. But observation will be unacceptable. This is not to be done when scomocolumnar junction or the upper limit of lesion was not quickly visualized when the results of an endocervical sampling was performed and CIN2 or it was ungraded. As CIN3 is considered an immediate cancer precursor, the treatment will always recommend observation and it is never acceptable except when it is during pregnancy. Otherwise, you have to treat it. The other treatment modalities are excision ablation, already discussed, and for follow-up after treatment of HSIL, the guideline says after treatment, HPV-based testing at 6 months is preferred, regardless of margin status of the excisional specimen, and it is also acceptable to perform colposcopy and ECC at 6 months. So this is the clinical management ACCP guidelines and follow-up of HSIL. Colposcopy, if the management option vary in different circumstances, if the age is I discussed the same. This was a study of role of human papilloma testing and cytology in follow-up after colonization. It said that testing for high-risk HPV 3 to 4 months after colonization is more sensitive than ASCA cytology for identifying women at risk for relapse of CIN2 within 2 years. And further studies are needed to evaluate whether HPV testing could be a standalone test in follow-up colonization. Another study of follow-up of HPV test with cytology as test of cure 6 months after colonization is reliable, and it concluded that negative testing 6 months after lead can be considered a reliable test as cure, as the 3-year follow-up results are consistent with neither HSIL or cancers. So in CIN2 patients, if CIN2 specified or HSIL unspecified, it has to be observed colposcopy and cytology if less than 25 years, and colposcopy and HPV-based testing if patient is more than 25 years, and at 6 and 12 months. And then 2 consecutive evaluation, both sketch and cytology. If CIN and on histology, then if it is reported, then HPV-based testing of the patient for more than 25 years, or cytology if less than 25 years in a year. And then colposcopy has to be done for CIN or cytology, sketch, AG, AGC, or HSIL with biopsy CIN. And HPV testing, if the results are negative, then she has to follow the ACCP guidelines, and HPV-based testing annually for 3 years, then test at 3 years intervals for at least 25 years. And if it is CIN3 specified, the excisional procedures has to be done and has to be followed like that. And for AIS, diagnostic excision procedure, to rule out the invasive cancer, we have to do excisional procedures. If the margins are positive, re-excision has to be done. If the margins are negative, hysterectomy can be performed, but conservative management should be done if future fertility is needed. And then if hysterectomy is even after hysterectomy, HPV testing has to be done annually for 3 years, and then test 3 years interval for at least 25 years. And if conservative management has been done, re-evaluation has to be done every 6 months for 3 years, then annually for 2 years is acceptable, and then she has to manage accordingly. And continued HPV-based screening every 3 years has to be done until hysterectomy or for at least 25 years. So for long-term follow-up in patients with histologic or cytologic HSIL, the initial HPV-based test at 6 months, annual HPV or co-testing is preferred until 3 consecutive negative tests has been obtained. And I'll skip this. So the guidelines for long-term follow-up after low-grade cytology, HPV, NRI-LM, or histologic LSIL abnormalities without evidence of histologic or cytologic high-grade abnormalities, what we have to do, if they're showing that how a patient with common low-grade screening abnormality, HPV positive, and ask us how we have to manage this. Initial screening, HPV positive, ask us, then immediate CIN3 plus risk is 4.5%. Then we have to do colposcopy. On colposcopy, if the biopsy risk is less than CIN2, the 5-year CIN3 risk will be decreased to 2.9%, and management will be 1-year follow-up. And the first follow-up surveillance will be HPV positive, and then the immediate CIN3 risk will be 3.1%, and she will have to manage with 1 follow-up. For second follow-up surveillance, HPV, if HPV comes negative, NILM, the 5-year CIN3 plus risk is no more, so she has to be managed with 3-year follow-up. And on second follow-up surveillance, if HPV positive and ASCUS risk is now the risk is no more, and she can be managed with colposcopy. So in patients with low-grade abnormality,
Sangeeta, we are running a little short of time.
Okay,
Can you wind it up?
You,
yeah.
If the patients with low-grade abnormalities who underwent colposcopy with CIN2 was not found, they can be followed by 3 rounds of negative co-testing, and the estimated 5 years CIN3 risk will be 0.03, and it will not qualify to return for 5-year interval. So we all know this. Okay. So persistent twofold increase in cervical cancer risk after treatment of histologic HSI risk will persist, and there is therefore continued 3-year surveillance is recommended for a minimum of 25 years. As cervical cancer seem to remain above general population level, continued screening should be done. We all know there is a mobile for ACCP guidelines. If you put all the details of the patient, the clinical situation, they will tell and what all testing you have done. So they will show you what are the recommendations. We have to do follow-up, or you have to do re-excision. This will be shown in this mobile app. Anyone can download it. And after hysterectomy, I think so, I will end here. And for this, there is the students can go.
I think we lost her due to her connectivity problem. So Dr. Ashwini madam, can you quickly, give your remarks on all the this thing, and then we will start with the panel discussion.
Yeah, Priya, I'm aware that we are running short of time, and all the speakers have done excellent job. And what they have taught us and emphasized is that early detection of cancer cervix is very important, and that's why we should take advantage of the pap smear, HPV.
Dr. Sangeeta, can you come out of this so we can hear Dr. Ashwini madam? Thank you very much, Sangeeta.
So
Yes.
not only early diagnosis is important, but also early referral to a person who has expertise to go ahead with ablative methods or excisional methods for conservative management of the cervical lesions is also very important. And Dr. Samar Gupte has told us about preclinical early invasive carcinoma and also advanced carcinoma. But even in advanced carcinoma also, whether we are able to conserve their fertility. So there are so many various issues which are there connected, and we don't end the follow-up there. But as Dr. Sangeeta told us very well, that a long-term follow-up is important so that there is no recurrence. So from early diagnosis till long-term follow-up, our postgraduate students should know that we have to do everything very methodically, and we should see to it that if the expertise is not available at our level of institute, then they should be referred to a proper institute so that the woman's management is done properly. So I think over to you, Priya.
Yeah. So that's exactly what Madam had concised it very clearly, that the management of taking up all these things and to manage the case, it's not only doing a colposcopy, it's not only doing a screening. And Sangeeta, you were really very good, but for short of time, I had to, cut you short. Don't this thing. I'm sorry for that. But you can see we were running late. But I think you have covered all the topics. You did cover everything, and you gave a very concise understanding of how to manage. Now the time for case management, case-based discussions. And do we have all our panelists first? Okay, I will share the screen of the panelists. I'm going to moderate this. And do we have Dr. Gaurav?
Yes, madam.
Fantastic. Parimala, I saw you right in the beginning itself. Thank you very much for being with us. Nisha, I could see you. Nisha, you're there, right? So yeah. Dr. Gaurav is Assistant Professor of St. GS Medical College and KEM Hospital. Parimala is a consultant obstetrician and with 30 years of experience. And you can see she's a Guinness record holder for the largest cervical cancer screening. And so many awards you can see. Aryabhatta Award, BSOG Award, and a great colposcopist and a very good friend of mine. Dr. Nisha Singh, she's a unit head and in charge of genital cancer control unit, KGMU, that is King George Medical University, Lucknow. She's a vice president of Association of Gynae-Oncologists of India, vice president of Lucknow OBGYN Society of FOGSI, and secretary of UP State Chapter, AGOI. Then we have with us another stalwart, Dr. Fahmida Banu, who is a senior obstetrician and gynecologist and minimally invasive surgeon, and she is at Hyderabad at Femicare Hospital. Welcome, Dr. Fahmida. Dr. Bharti, are you there? Couldn't see you. Dr.
Yes,
Bharti?
I'm there.
You're there. Fantastic.
Yeah, right.
So Dr. Bharti is from Kolhapur, and she's a senior gynecologist out there, and she is also running FOGSI colposcopy course. Her special interest is in colposcopy, laparoscopy, menopause, and adolescent, and she does a lot of training programs. And also she passed international exam of IFC PC with top scores. And now we do not have Dr. Vasu, but instead of that, we have Dr. Mala, who is going to take his place. So I welcome one and all for this, and I'm going to share my screen for the case managements. Am I audible and my screen visible?
Yes, ma'am. Yes.
All right. Thank you very much for being with us. Now we have been talking. Now today's case management, what am I going to do is, we have heard so many guidelines. I'm going to take up the WHO guidelines, all right? And because WHO has given a clear cut, and they are the latest guidelines. They have literally latest 2021, and they have come up with algorithms, very easy algorithms to understand, because we want to know how to take up the case. That's our main motto and the goal. So this I have taken up from this WHO guidelines for screening and treatment, second edition. And this is within this, it had come in 2021. They gave two approaches: screen and treat approach, screen, triage, and treat approach. All right. And so screen and treat approach is decision to treat is based on the positive primary screening test only. Screen, triage, and treat approaches, the decision to treat is based on a positive primary screening test, followed by a positive second test. That's a triage test, with or without histologically confirmed diagnosis. That's very important. Underline that statement. So we should know about it. Let's understand how to take these up into our clinical practice. Because very simple approaches, you know. They've given 7 algorithms, and I have brought cases for all these algorithms. All right. Let's go through it. So screen and treat approach, the first one is VIA. You can screen with VIA or you can screen with HPV DNA. Screen triage, you take as a primary screening with cytology, or an HPV DNA, or an HPV again a DNA. So all these tests mainly are based with HPV DNA, but various triaging methods. So when you're telling about screen and treat, that's say, suppose if you are doing with an HPV NAT test and that's positive, then you can, you know, treat without even a triage. So that's there. Why is this so much focus on treatment? Is we want to achieve the goal of 90-70-90 and cancer elimination by 2030. So, you know, these are a little bit, that's the reason the focus mainly is on treatment. That's 90%, 90-70-90. That's the thing. Then after another one is, these are the NAT approaches, that is with HPV. So what does it say is, after a positive primary screening with HPV test, you look out for the eligibility criteria for treatment. So ablative eligibility criteria, if not, then you go for a lens. So this is a single visit approach. And post that, you call them up after 1 year. That's the main thing. Okay. Now I'm setting the stage now for all the cases which is going to come. So screen, triage, and treat approach is you screen with the HPV test, all right, and if that's positive, you go about doing a second triage test, either with genotyping or VIA or colposcopy or cytology, followed by colposcopy. Now, after the positive primary screening test with HPV NAT, but a negative triage, what will you do? Here, you do not treat the patient, but they do need appropriate follow-up evaluation at a specific date. And according to the recommendations, for the general population 2 years, for the HIV population 1 year. All right. And after a positive primary screening test with both HPV NAT as well as a triage, then if the patient is, you know, eligible for ablation, go for it. Not eligible, go for excisional, and otherwise refer. and you have the follow-up to be done after 1 year. So these are all the things. And now I'm going to go with the cases. Now, all said and done, we have to know how to use this in our clinical practice. So I brought cases accordingly. So now first, let me start with Dr. Fehmida Banu. Dr. Fehmida, screen and treat regarding VIA based. So can you just chart out this algorithm for the benefit of the audience?
Very good evening to all the esteemed colleagues. And thank you so much, Dr. Priya Kumar, for bringing the cervix to the spotlight. So really, your work is amazing. Thanks for giving me opportunity to share the academic platform. The algorithm is primarily through VIA screening. This can be divided into VIA negative and positive and suspected. If it is negative, we have to put them in the follow-up, and once in 3 years, we have to keep doing this test. If it is positive and we see sharp margins and dense aceto-white areas with or without the raised margins, then we can consider it as a positive, and we should start selecting one of the modes of treatment. If there is any suspected areas like a highly suspicious of malignancy, a growth is seen, or highly vascular or bleeding on touch, then we have to refer for further evaluation. And once it is positive, we have option. Either we can do ablation techniques or we can do lids. Ablation techniques, once again, the earlier speakers have enumerated. We have various ablation techniques: cold ablation techniques, electrocoagulation methods, cold coagulation methods, and lids. Once ablation is done, this comes under see and treat method. And in other group where the thermal ablation technique is not suitable, we can go for long loop excision. Personally, I prefer long loop excision because we can see the clear margins, and we can take a good amount of biopsy specimen. The minimizes the chance of missing any malignancy or pre-invasive lesion. And areas where we suspect malignancy, then we have to refer for further evaluation in the form of colposcopy or colposcopic guided biopsy.
Thanks a lot, and very clearly said. So now one case which I've brought, Parimala, Dr. Parimala. So now this is the case where this is a camp setting. Can you just enumerate on these photos? 35-year-old, she has come with white discharge, and we have done a VIA and VILI. Dr. Parimala, are you there? Dr. Parimala?
Can't see her.
Okay, so will anyone, Dr. Mala, will like to take this?
On the posterior lip, we can see areas which are aceto-white as well as villi positive. And since we can see the entire lesion, we can take her up a large loop excision biopsy of this lesion, and then we can get a good histopathological finding of this tissue also, because the entire lesion is visible. So I think we can take the entire lesion as a long loop excision biopsy. Ablation can also be done, but then we would like to do a large loop excision, as Dr. Banu also said, that we prefer to do large loop excision biopsy because then we get a good tissue for the histopathology, as well as we can also test the margins.
Nisha, Dr. Nisha, are you there with me, with us? Yes. Now, Nisha, do you agree with Dr. Mala? Can we do an ablative in this as well?
So a very good evening to all. Now that we have seen this, the management will depend upon what facilities you have. Where is it done? Suppose it is in my center where we have colposcopy, and then I can do a colposcopy and I can do a see and treat. So once colposcopy is done, most probably the findings will be showing a positive lesion and the sweat score would be more than 5, but we confirm that, and there itself we can do a loop excision in this case, and the tissue goes for histopathology. Suppose we do not have a colposcopy and it is in a setting where they do not have a colposcopy. LEAP also, if they have, they can go for a screen and treat. But if they don't have and they have ablative procedures, they should take a biopsy first and then do the ablation over that. So that now ablation also, if it is cryotherapy, the tip probably would not reach this area.
Absolutely.
So maybe if it is thermoablation, then maybe it can be covered with that. But with a cryo trip, I doubt that it will be able to cover that. So that's why the ideal is the LEAP in this case after a colpo, but it can be a direct LEAP also. If you don't have a colpo, that's a screen and treat and the tissue goes for histopath. But if you are doing ablation, you better take a biopsy and send it and do an ablation there with the thermoablation, as I said, so that you will have the histopath result also.
Absolutely. So now the question goes is like, okay, now we are quite, we have been doing LETs time and again, and we are now, I mean, we are confident in the LETs and all that. But suppose if the doctor who is doing in a camp setting is not confident, do you still prefer that ablation? Because what I was trying to understand is this area is going really inside, and even as a thermal ablation, you have to be very careful. You have to be really this thing that if you're using a thermal ablation, then at least as what Debabrata had said, you can overlap your things and you can actually do it, but see to it that this all cases has to go, this whole thing.
Actually, I feel that if this kind of lesion is there and you do not have the facility or the expertise to handle it, it is always better to send it to a place where it can be better handled. So precisely that message also goes, yes.
Yeah, very correct. Very, very correct. So then we have done an LETs on her and we got a report of CIN1. I mean, it's okay. I mean, having a CIN1, we do not expect that. And the margins, the main thing what we have to see is the margins. Now, Dr. Bharti, you're with us. Now, since we have done this, okay, this is a camp setting, okay, and we could do it that there and then. How do you follow up these cases? How will you explain to the patient? How will you counsel her after doing this?
Okay, thank you so much, Priya, for giving me the opportunity. First of all, after doing the procedure, we have to explain her to report immediately if she develops any sort of bleeding, abdominal pain, fever kind of symptoms. And as far as our lesion is concerned, we have to call her for follow-up after 6 months. And then we have to do her screening, whether we have correctly treated her or not. For that, if the facilities are available, definitely a colposcopy is going to help us, because we don't have her initial screening reports like cytology or HPV. Directly, we have screened her in camp. So we are treating her on the basis of see and treat type of method. So we don't know whether she's going to come for a follow-up or not, but it's our duty to tell her that the lesion is not very serious, but we cannot neglect it, and you should follow her up after say 6 months or 1 year. And if possible, you do cytology and colposcopy at that time.
Absolutely. So she was called after 6 months, and you can see over here that there was a fantastic, all the thing has gone away. This is your 1 minute 34. We had done a colposcopy on her post follow-up, and then the lesions have completely been treated. I mean, there is no lesion left out. Now, Dr. Bharti, I want to know, once we have done this and we have seen this as negative, it's become normal, how will you now convince this patient? Till when? I mean, we have heard Dr. Sangeeta saying that, yes, we have to call her up till 25 years and all that. In your experience, does the patient do really take the advice and they heed to your advice?
Yeah, they won't listen if at the initially we tell them that they have to come for a follow for 25 years. Don't tell like that. Just tell them that after 6 months, I'm going to look at you, whether I have treated you properly. And then after 1 year, we will do her screening by HPV method. If it is negative, then definitely we can repeat the testing after say 2 years. And when the consecutive report is also negative, she can enter into the routine screening modalities.
Fantastic.
But we have to follow her up, because once.
Now, what will be your routine screening modality, Bharti?
Yeah, routinely I do liquid-based cytology. If the patient is affording, I do co-testing with HPV. But nowadays I have started combining liquid-based along with a via testing in the OPD. So that is giving me very good results.
All right. So now,
Priya,
yes.
Nowadays, patients are all well educated. If you can tell that VIA is in 25% of cases false positive, then they may understand the significance of follow-up.
Very well said, Femida, because this is something I really wanted some of you to really come out with, because what is happening is we say screen and treat and camp setting, patient ke paas paisa nahi hai, but we are supposed to even talk about this HPV, and rightly pointed out by Bharti, we have to say these things. And we have to even mention very clearly that it can be, sometimes VIA can be false. This thing also you get reports, and hence talk to her about cytology and HPV. Okay, I'm getting another wonderful case for you all. Now, this is a case, a 42-year-old. She's, she comes with complaint of menorrhagia. She's just married since 1 year, late marriage. So she is anxious for child. She has an intramural fibroid of 5 by 4 centimeter in size with occasional white discharge. And what's happened is she has come to me and I've done her PS and I found her cervix to be unhealthy. There and then I've taken a co-test and both her reports have been NILM and HPV is negative, but her cervix is unhealthy. So these are the reports. LBC showing NILM and HPV showing with hybrid capture is negative. Dr. Mala, can you just say, I mean, in this case, should I go for a colposcopy or what do I do in such case?
If she's having an unhealthy cervix, it is an indication for colposcopy. Normally, when we say colposcopy should be done for screen positive, whether the cytology is positive or HPV DNA 1618 is positive. But if there's an unhealthy cervix or persistent discharge even after the treatment is there, then we have to think for colposcopy in this particular case.
Fantastic.
And
so I've done a colposcopy.
Dr. Priya.
And even if there's a postcoital bleeding or if there's a intermenstrual bleeding and the cervix is unhealthy, patient is symptomatic, and on per-speculum examination, you find the cervix is unhealthy. These can be the indication for colposcopy to confirm confirmation.
Dr. Femida, you wanted to say something?
Because she's 42 years and anxious to conceive, the endoscopist in my heart is jumping and saying, why don't you remove the fibroid?
All right, but this is your endoscopist can sit for some times because we are onto the cervix today. All right, so now
me. Okay.
All right, Dr.
But she's married only for 1 year.
She's just married for a year.
She must be a software engineer.
Okay, so we have done a colposcopy, and Mala, can you just quickly take us to the sweet scoring?
Yeah, we can see the entire transformation zone is seen, and there's a fine mosaic is there, fine punctations are there, but Lugol's is positive and acetobite area is also positive in the anterior lip, starting from 11 o'clock position to approximately 2 o'clock position and the anterior lip. And even in the posterior lip, the acetobite area is positive. And this is also Lugol's positive. So the sweet score comes out to be 2 + 2 + 2 and about 6 or 7. It comes out to be about 6 or 7.
Absolutely. So,
and it is covering the more than 3 quadrants of the cervix.
Yes.
So it's a big lesion that's we're looking at.
So now see, this is just, if we had just gone with, co-test, and we could have missed out these cases, no? These are very, very important to understand how to take up these cases also. So did a histopath, and then some area is SIN 2, see here over here, some area SIN 1 and all that stuff. Now, how do you proceed, Dr. Gaurav?
Yeah, I think in such a case where you have some areas with CIN 1 and 2, I would like to do thermal ablation in this sort of case. I think 11 to 2 o'clock, both anterior, posterior lip. It's a good thing. Probably thermal ablation gives some good results, especially if you want to conceive, if you're keen to conceive.
Exactly. So you will not think about excisional. You will think about.
Well, excision would be probably a second choice, considering she's 42. I mean, the pregnancy is it's very precious at this age. I would also like to do an AMH, the fertility side, see what her chances are of getting pregnant on her own, or whether she needs support.
Of course, of course. So here we have, as rightly said, we've done a thermal for her, and you can see she's completely ablated. And then Dr. Fahmida, how will you then follow her up?
Depends on the histopathology report.
We have ablated her. Yeah, SIN2 some places and SIN1 some place.
So
but we've ablated her.
For follow-up for yearly ones. Meanwhile, she will continue her fertility.
Of course, your fibroid thing is really dancing on your head.
Yeah,
So,
I just wanted to
Nisha.
say, because now it is a post-treatment case. So the test of cure that you have to do in this case would go at 6 months first, and you've done an ablation. And particularly, this was a very peculiar case that HPV was negative, PAP was negative, and you found something on the only on the colposcopy. It doesn't happen always, but once in a while, it's okay. So I think at 6 months, you should do that test of cure in this case. And I mean, you may do it with either of the screening test, or you may go for a colposcopy directly. It will be a little bit of, this thing, but definitely a follow-up is required, because you have treated a case of CIN in this case.
Just done a follow-up. At 6 months, I did it with, I mean, of course, I had to see, that whether it is healed properly or not. So colposcopy was done. And the small area which we found, I mean, this looked like this thing, but I took a biopsy. This is chronic cervicitis. And this came out to be chronic cervicitis. Now what to do? Like, how next to take it up? This is a case to you. Of course, I've done a TOC also, as rightly said by Nisha.
Yes. Yeah.
I've done an LBC, I've done an HPV, and again, everything is normal. So now how do you then, Nisha, how will you now call her up? This case, what will you say?
So after this, she can go on a routine screening protocol. Once you have done the test of cure that was negative, and then you have even actually taken a biopsy and it came out to be. So she can go on a regular screening protocol, or maybe, once more you can do after a year and then put her on the regular screening. That's
so, but now can she become pregnant? Her question is, can I become pregnant now?
Yeah, she can go for pregnancy. That's not a problem.
And of course, as rightly said, see that intramural fibroid also has to be dealt. So where we have done a lap myomectomy for her, in fact.
So only one thing I would like to say, because we gave a message through this that if the cervix is unhealthy. So let's be very clear on that is a subjective finding, and really, experts seeing and then finding, despite having the HPV and this thing negative. So there should be a balance. We should not increase the number of colposcopies also, that everybody is saying that this is unhealthy, this is unhealthy. So that balance somehow has to be maintained. So it was the only point I felt in this.
All right. So now Dr. Parimala, now that's done with the algorithm 1. We go with algorithm 2. Parimala, are you there? Because you couldn't answer last time also. So I can't see her. Because I'm sharing the screen, I can't see the participants. Is Parimala there? If no,
yeah, she's not here.
So, okay, madam, then I will continue. See, now this is the screen and treat now with HPV based. What is this saying? Anyone wants to take it up? Anyone wants to take up this HPV algorithm?
Okay, I will take.
Yes, Bharti.
HPV DNA, we are using it as a primary modality. If the test is negative, straight away she can be called up for follow-up after 5 years. If the test is positive, then we have to proceed further. Either you do genotyping, then you
no, this is screen and treat, Bharti.
Okay, so
this is direct screen and treat.
Yes. Okay. So
not
if HPV test is positive, then you have to think about the ablative or excisional method of treatment. And since it is screen and treat, depending upon the criteria that are fulfilled by the lesion, of course, when you are doing HPV, you are supposed to do wire testing. Am I right?
Absolutely. That's because you want to know. Now the via is done not to identify the lesion. The
but for
via is done
modality
to,
of treatment.
yes,
Yes.
the what type of modality you want. That
Yes.
means what does this algorithm says? This algorithm says कि आपके पास HPV आया है, you have an
Yes.
HPV positive, and you're straight away
And yeah.
treating, you know.
Yes.
You're putting a VIA to understand SCJ, new SCJ, and
Yes,
understand
yes,
TZ.
definitely. And modality of treatment can be decided upon that. If the lesion fulfills the criteria of ablation, straight away go for an ablative treatment like cryotherapy or thermocoagulation, depending upon the facilities. If the lesion is quite big, then go for LEEP or leads. Again, if the facilities are available, and if you suspect that the lesion is somewhere near the growth type of lesion, then directly refer her to tertiary care center.
Absolutely. So I've brought one, again, a fantastic case. A 36-year-older, she comes with menorrhagia, okay, for in 6 months. She has multiple fibroids. She goes to a gynecologist. Now, the gynecologist is very, she's been doing HPV co-test for everyone who walks in. So she has done her co-test and she has found LBC was negative, NILM, but HPV came out to be 16 positive. So that's the case. So now this is it. She is HPV genotype 16 positive. So Nisha,
So
can you tell
yeah.
this?
So what we understand that the HPV is positive, and we know the genotype also, like it's the high risk type which is positive. So it she's 36-year-old. For the screen and treat approach straight away, you can go for a treatment in this case. Considering then you have to do that VIA as we were talking to know what is the lesion, where is the lesion, will it be managed by ablation itself or it needs an excision. So for that purpose, you need to still do to localize the lesion that is required. So if it is a big lesion,
read
you
this?
will have to go for
Yeah. So Nisha, can you take it up this also, that this is it, what I found?
Yeah, so this is a big lesion that is there. I mean, so the leap has been done. We can see through the pictures, and because it is involving almost all the quadrants and it's a big lesion, so therefore the leap has been done. Actually, the pictures are small. I cannot tell you the minor details of the.
Of course. No, we don't here.
Yes.
The
So,
basic thing is understanding that HPV is positive. When you've done a colposcopy and we have found that, there's acetovite areas, dense acetovite areas coming up over here, then dense acetovite areas coming up over here,
it
at
is
all.
more than 2 quadrants, and it's a bigger one. So that's why the.
And even you can see this in the columnar epithelium also, there are these dense acetovite areas. So what I thought was, rather than doing all this, let's do a proper excision, and that we get also a histopath.
That's the best part of the LETS, that it is a treatment plus you got the diagnosis, the tissue also available for the diagnosis.
Now, the report read to me is HSIL grade 3, the margins are free. There was some minor tension arised when we saw this report, was that some places, you can have a micro invasion close to carcinoma in situ. So this really bursect them, and they were also very, very tensed. That the patients were very tense that are gaye kisi aur ke liye hua kuch aur, and that micro invasion part and all is really very troublesome. Can't digest this very easily. So they took up a second opinion. I'm sorry about this slide because it was just a photo click which I took. So this was taken up from Dr. Bojas. The slide was again read. And part of little solace came up for us that there is no microinvasion, but yes, the underlying endocervical glands are involved and there's no evidence of invasion. That's one thing. So again, it is a real tension because now, the follow-up, and one thing was she didn't have any symptoms at all related to all these things. She's just going to a doc for a menorrhagia and a fibroid. That's it. So Dr. Bharti, now, we all understand this is a real tension type of a picture. In this way, how will you now counsel her? How will you take her up? What will you tell to her?
Yes, for this, we have to, again, same thing, we have to explain her regarding this morning symptoms and call her for follow-up after 6 months to visualize the cervix. If you have a colposcope, it's well and good. You follow her up by colposcopy. And after 1 year, call her for routine testing because she was HPV positive. So again, you have to do her HPV screening after 1 year, not immediately after 6 months, but you do it after 1 year. And depending upon the result, you have to call her for follow-ups. Suppose again the HPV 16 is positive, the keen follow-up is needed. If the HPV 16 turns out to be negative, then you can repeat the smear, say after 2 years, and then if it is negative, call her after 5 years.
Dr. Priya, can I
Yes,
tell
Dr.
one point?
Yes, please.
One thing is in the first biopsy report also, the margins are free. That is a very good thing. They went for second opinion, that is their wish, but in the first report, the lids biopsy margins are free. That is one thing very positive to console her.
Absolutely.
That is very, very important point. Second thing, when her complaint is menorrhagia, simultaneously we have to do a diagnostic office hysteroscope to see any intracervical or intrauterine lesions which may be coexisting.
Yep. Very good. And this was done actually, not simultaneously, it was done by the doc previously also when she had, before sending to me. She had evaluated her endometrium as well. And that's a very valid point, Dr. Fehmida, you brought it up over here. And we did a relocolposcopy, and definitely we, as I was telling in Gitanjali's talk, when I just had to interrupt and come in the middle, that, parallel blood vessel patterns are really very interesting blood findings in the blood vessels. So these are your parallel healing patterns. And when I saw this, I was really very happy. And I, just for the sake of, because they were so tensed, these patients, and I just did up, it's not required, okay? Don't take it up that this is a recommendation, it's not required. But just to be on the safer side, I just did a punch, and it also came up to be a benign regenerative squamous epithelium. I taken a punch from 12 and 6 o'clock. So to just ensure and tell to the patient, ki, yes, Baba, you're completely clear. You don't have to now cry and make a hue and all that. And you can really rest assured that it's okay. Now you can concentrate on your fibroids and all that thing. And we did a test of cure, as rightly said by Bharti, that we did it after a year, and her HPV is negative. So that's exactly what we have done. And we have also told her that surveillance of 20 years is necessary. Okay, now we go to the third algorithm. Now, Mala, Dr. Mala, can you take up this?
Yes, this is the third algorithm. When we do cytology as a primary screening and then triage with colposcopy for treatment. So if the cytology is ascus or negative or more than ascus, if it is negative, then every 3 years we have to repeat the cytology. If it is ascus, then we have to triage with HPV testing. If HPV is negative, then we have to rescreen in 3 years as we do for the cytology. But when the ascus is there is ascus and HPV is negative, we can counsel the patient, reassure her, and then we can come back to 3 year cytology rescreening. But if HPV is positive, then in that case, we have to do colposcopy, and if necessary, we have to take a biopsy if necessary. If it is more than ascus, then we can directly go for colposcopy even without doing the HPV test, depending on the patient's history, age, etc. And when there is more, suppose if there is LCIL or HCIL, then we can go directly for the colposcopy and further management based on the colposcopic findings and histopathological findings. Perfect. Suppose the patient is having ascus and HPV is negative and we are screening after 3 years. After 3 years, if it is negative, then again she goes for 3 years cytology screening. But after 3 years, if it again comes at positive for ascus or more than ascus, then again we may have to do colposcopy for her, and depending on the colposcopic findings, we may need to do cervical biopsy.
Perfect, precisely. So now I have a case, 59-year-old. She's a case of HCV positive. Okay, she's from liver transplant, and they have done, because she's going to go for a liver transplant. She has been done, PAP has been done on her as a routine pre-op screening, and we find that her PAP test HSIL is positive, HSIL. She is a case of HSIL. Now, Nisha, HSIL cytology, the relevance of it, can you enumerate?
Yeah, so as we saw in the chart also, and let's just have it clear in our minds, LSIL and above, we have to go for a colposcopy. And HSIL means it is a high-grade squamous intraepithelial lesion, high chances for its conversion, or even sometimes, coexistent microinvasive lesions could be there. So this has to be handled seriously. If it is a HSIL cytology, we have to go for a colposcopy evaluation. And depending upon the findings, we have to do depending upon the SWED score that we get, we have to do the treatment of that. In case we find an endocervical lesion, then of course the endocervical biopsy and the endometrial biopsy will have to be added. But if it is limited to the transformation zone, then based on the score, we have to decide whether we go for a excision, mostly excision in high-grade intraepithelial lesions. Yeah.
So here we have this, and you can see how much is the bleeding on touch itself.
Yes.
And all these signs, these are the signs where we were talking about rich signs, and all these signs are really positive over here. And there is a RAC sign. Now you can see mustard staining. And when we took a biopsy, it came up to be carcinoma in situ and severe dysplasia.
Yeah, this is what.
Exactly. So that's a punch which we had got. And Dr. Gaurav, in such case, how do you proceed then? Now, this is the case. How do you proceed? She has a liver transplant also to be done. And she is this also. What will you do?
Yes, so since she's 59 and she has a liver transplant, I would rather go for a definitive surgery, a radical hysterectomy in this case, with completeness, whichever way you do it, open or endoscopic. But since she's undergoing a transplant, I would like to do a complete procedure.
I'm sorry, Dr. Priya, radical hysterectomy here, it's a severe dysplasia, we agree, it's a CIN3. A radical hysterectomy will not be required. Either you do a cone and confirm there is no invasion. If there is invasion, of course, it will be. Otherwise, for CIN alone, we won't talk about radical hysterectomy.
But Nisha, I would have, my opinion in this case was, as she's going for a liver transplant, and then she's going to be on all those, suppressors. So knowing that, will you not go for a definitive?
No,
knowing the fact that, there can be a recurrence.
Hysterectomy, you can go for
hysterectomy, not radical.
But radical, when you say it is lymph nodes, dissections and all that without having an invasive carcinoma. Yeah, that's what the point.
You can go for hysterectomy.
Yes, you can go for hysterectomy.
But
so
not for radical.
Okay. Okay.
So that's why I said whenever you have such a high doubt of invasive coexistent may be present, then in that case you do a cone first, maybe a leaf cone only, and then you take the decision so that doubt doesn't remain, because it is CIN3.
As the Priya said, if the patient is going to be on immunosuppressants, it is better to perform hysterectomy, not radical, but hysterectomy. Otherwise, immunosuppressant will
aggravate. It was the radical term that I just kind of
we had objection to the radical term because
agreed, boss.
Fahmida. See, I'll tell you what had happened in this case. In fact, because we had to understand her nodal status, we did a CT MRI also. Of course, we had to know that, otherwise we had to take an understanding what is to be done in this case. Couldn't leave her in that way. And of course, we returned back because she was sent to me only for colposcopy. Now, she is a case from Kokla Ben, Ambani Hospitals, and there the gynae oncologist took up they did a radical on her. In fact, they did a radical, and then they said that we can't take a chance. She's a CIS, maybe They could have gone doing a conization, as rightly said by Nisha, and tried to find out, or even at least, but I don't know. She actually landed up like that, and finally she went in for this thing, So definitive surgery is 100% required. All right. Now we go to Dr. Fehmida. Can you take up this algorithm? Algorithm 4.
So HPV DNA screening and HPV 16 and 18 triage. So here, if it is negative, then they can be put in the follow-up of once in 5 years, and like in any other general population. But if they are positive, then they belong to the high-risk group, because 16 and 18 both are positive. Then we have to do determination of the treatment, whether it is in the form of definitive treatment, ablation, or leads. Personally, I definitely prefer leads over ablation in such cases, because I want to exclude any other cervical pathology which is harboring there. Suppose if there are other lesions which are detected through via in addition to HPV 16 and 18, then we have to take her up for further evaluation in the form of colposcopy or colposcopy guided biopsy. Depending on the biopsy, we will treat her further. But once it is HPV 16 or 18, we will consider it as a high-risk case and we treat more aggressively.
All right. So if there is no colposcope with you, then you can do a VIA triage.
Yeah.
Yes. So I bring a case for you. So now this is a 30-year-old. Okay, she's asymptomatic, and in fact, in one of the it is a quite a high resort setting screening this thing, center, and she was screened there. She was HPV DNA positive. Now this is her report. Hybrid capture came out to be 571 RLU, quite a high one. Above 1 RLU is considered, and above 1.8 now, as per the latest guidelines, is considered positive. And then we triaged her, and that, as I told you, it's a high resource setting. So we did have mRNA also with us, and we did an HPV genotyping to understand what is the case, and she is 16 positive and mRNA positive also. So Dr. Bharti, we did a colposcopy. Can you read the colposcopy and can you guide us through it?
Yeah, this is transformation zone type 1, and I can see a thick acetocyte lesion on the posterior lip extending right from I can say 4 to 7 o'clock. It's a dense acetocyte. I'm not able to see the vessels on it because the picture is small, but I hope there are pores punctations on it at some places. And the lesion is occupying 2 quadrants, and the iodine or Healy test is also positive. The lesion has not stained with iodine. So
how much will you sweet this to, Bharti?
Pardon?
How much will you sweet this to?
Yeah, I will sweet it 7 to 8. So it will be a high grade type of lesion.
Yeah. And so Dr. Gaurav, in this case, how do you proceed then? Will you think of doing an ablation?
She's 30-year-old asymptomatic. I think she is HPV positive. And in such a case, I would like of the loop excision of the acetocyte areas.
Can you do an ablation in this case? Anyone? Can you do an ablation in this case?
No. Actually, it is covering more than 2 quadrants.
Yeah.
Almost 3 quadrants have been covered. So not an ideal candidate for ablative procedure.
And
plus it's going inside, right?
And Priya has given us a higher end setup, isn't it, Priya? So we will like to do lids, not ablation.
Perfect. Yeah. And there is a reason for doing a less, because again, you can see this is going endocervical.
Yes.
Yeah.
Where you just cannot do an ablation. That's the point which I want to bring to the notice. And we did LETs on her, and the findings are CIN1, 2, some places and all that. Now Parimala is not there, so anyone wants to take it up. Now, how will you call her up for follow-up? I mean, we have done this follow-up thing, but quickly, somebody can tell. Mala or somebody can tell.
Chemistry will be
after 6 months.
IHC, somebody said very good. Bharti?
Yeah. because it's SIN 1, SIN 2, not confirmed. So it's better to conclude whether it is a SIN 2, and depending upon that, our management will change. So
but
if
we have
facilities are
done
available,
we have done this. See, I'll tell you another thing. mRNA has come positive. That itself shows that this is an integrated HPV. So even if I do the IHC marker, she might be 16 positive. I mean, a mild 16 positive also will be there. But she's definitely an integrated HPV. So having an integrated HPV definitely warrants that we go and do a proper, excisional method. And as it's going endocervical, definitely, yes, we will take we have done that. And this is a relocolposcopy after 6 months.
After 6 months, yeah.
We did a test of cure. She is negative now, and that's how we follow up every 5 years. We call her up till 20 years. So this is the case. Now we go for the next algorithm number 5. Anyone, Mala, or anyone will want to take this up?
Yeah, when we screen, triage, and treat HPV as primary screening, and we triage with VIA. So HPV DNA testing, self-sampled or collected by the clinician, if it is negative, then every 5 years we can do as we do in the general population. But if HPV DNA is positive, we triage with VIA, and if the VIA is also positive, then in that case, we have to assess the patient by colposcopy and see whether she is eligible for ablative procedures or if she is not eligible for the ablative procedure.
This is not from colposcopy. This algorithm is fitting up for VIA.
VIA. Yeah.
VIA, because she doesn't have
colposcopy. If it is positive, then we can assess whether ablation can be done or not. If she is eligible for ablative procedures, then we do the ablative procedures. If she is not eligible for the ablative procedure, then we go for large loop excision of the transformation zone. And the histology, depending on the histology, we do the further management. If it is by VIA triage, we suspect cancer in that case, then she goes as a protocol for the further management. So HPV DNA positive, we have to triage with VIA.
In case where you don't have a colposcopy, I mean, whoever wants to follow up this protocol, I mean, see, there are many people say, no, we are not colposcopies, we don't have colposcopy. And then those lame excuses don't fit here. That you can always do an HPV, you can always do an VIA, and you can always take the patient and treat. No, these are different modalities of how you can treat without any lame excuses coming up. Now, this is a 37-year-old. Now, she is...
Can we please wind up, because it's really far behind schedule we are going. I know everyone is eager to learn much more.
Yes, we are almost done, madam. Only 2 are remaining. So this is quickly, we'll wind up in 5 minutes. So now this is, since 3 years, HPV was done, and HPV is positive, 18 positive. And of course, this is the VIA done, and that is dense area. And this is actually infiltrating squamous cell carcinoma. So now we have with Dr. Gaurav. This is our second last algorithm. Gaurav, can you take it up quickly?
Yeah, so this is HPV DNA testing. Either you can see if it's negative or positive. In case of negative, you rescreen with the HPV, where you decide if she's HIV positive or not. If she is not, then you retest in about 5 to 10 years. Otherwise, about 3 to 5 years if she's living with an HIV positive or she has positivity. If the HPV DNA is positive, then you go for a colposcopy, and the management is based on the diagnosis on colposcopy.
So this is a 40-year-old. I'm going to really rush through this and just show the cases and quickly finish it off. So 40-year-old, she comes with reddish white discharge. Her HPV is positive, 18 is positive. And then we have done a colposcopy. You can see these are, grading 2 Swede 6 high-grade lesion. But when we took a biopsy, she came only CIN1. But exactly, we have to understand how to treat her. And because this is going endocervix, we didn't take a chance, and I went ahead doing I'm sorry, I'm taking it fast because we have a post test also to do. I took up a side-to-side LETs, and that came up to be SIN2. And then we have followed her up after 1 year, and that's negative. All right. And another case is a 42-year-old. Occasional postcoital bleeding, white discharge, 16 positive. You can see this case, 16 positive. And this is the case where, again, doing this thing, Sweding to 10 and taking a punch biopsy, adenocarcinoma. Then is a last where, HPV is taken, triaging with cytology, and you can further take it up. So here's a 32-year-old, repeated postcoital bleeding, 16 positive, triage with cytology. She is ASK-H. 16 positive, ASK-H. And again, we did a colposcopy. We found out this is a high-grade lesion. Took up a biopsy. She is a proper case of, well-differentiated squamous cell carcinoma. And so that is now the one-liner. I want to quickly now, finish this. So one-liner from all the participants, a take-home message for all our delegates.
So I just want to say that this is, apart from knowledge, the skills are important for management of these lesions. So whosoever takes it up, learns it, and then does it. So not just by following the charts and do whatever you like, it's better to learn the skill and then do it.
Yeah, thank you. Dr. Fahmida? What is your one-liner message to everyone?
Early detection is best protection.
Super. Bharti?
Yes, must advise screening for each and every lady that comes to your OPD despite her symptoms.
Mala?
Yeah, we must do opportunistic screening for all our patients, whether they are symptomatic or asymptomatic, and definitely not be scared of any abnormal cytology that we get. We have to learn to either see and treat or see, triage and treat.
Fantastic.
And
Dr. Gaurav?
systematically.
Perfect.
Yeah, I think
Dr.
prevention
Gaurav?
is better than cure. Individualize the treatment and completeness of procedure.
I think that's done from our end. And so now, Dr. Lakshmi, madam,
Yeah,
we
please
go for
have
a
a
test.
post-test. Yeah. Please quickly have a post-test. Yeah. So dear
Malaji, I think
participants,
Bhagya is not
yeah.
there. Will you take up the test?
Yeah, our technical team will be posting the link in the chat box, and you will be given 10 minutes to solve the 30 MCQs. So Jignesh, please post the link.
Yes, ma'am.
Yeah, and start the timer as well. Have you posted the link? Yeah. Once you post the link, then only start the timer.
Ma'am, link posted.
Yeah, now start the timer.
Yes, ma'am.
Can't see the timer. Jignesh, post the timer. Have you started? Jignesh, timer?
Yes, ma'am. Timer has been started.
Can't see it. Okay. Post a link again. You post the link. I can see the link. I will post.
So that's the end of it. Thank you very much. And Dr. Mala, can you take it up from here?
Mr. Jignesh, please show the questions. Can we read? Mr. Jignesh, will we upload the questions?
Yes, ma'am.
Colposcope
One
was
minute.
introduced first time in Germany. Colposcope was invented by Hinselmann. We can't see the sheet, Mr. Jignesh.
Just a minute, ma'am.
Okay.
We're getting pouring remarks. Thank you, one and all. And yes, now Jignesh has started.
Colposcope was first introduced in Germany. Colposcope was invented by Hinselmann. The third question, the following feature during a colposcopic examination is not important diagnosing grade of cervical intraepithelial lesion, that is presence of Nabothian follicle. Next, the colposcope head does not comprise of video monitor. Next, identify the instrument. This is endocervical speculum. Next, as per IFCPC nomenclature, features of general assessment of cervix by colposcopy includes all except satisfactory, unsatisfactory. Next, excisional treatment is indicated in women with biopsy-proven CIN1 and epsilon cytology. Next, which is not true about interpretation of SWEET score. 4 to 5 is low grade. Next, normal colposcopic findings are all except columnar coarse mosaic. Next, follow-up after treatment for CIN is up to 20 years. Minor grade lesions are fine mosaic. IFCPC excision specimen dimensions are all of the above. That means length, thickness, circumference, etc. Type of excision is decided according to the depth of lesion. Next, the temperature achieved in thermal ablation is 300 degrees centigrade. Actually, it is more than 100 degrees centigrade. Next, thermal ablation treatment is up to 20 to 40 seconds. Next, women who screen positive are eligible for ablative therapy if there is all of the above. Next, WHO suggests thermal ablation be provided a minimum of 100 degrees centigrade for 20 to 30 seconds using as many applications as needed to cover the entire lesion. Next, 18th question. WHO suggests that trained nurses, midwives, or healthcare workers as well as physicians may perform thermal ablation in order to ensure the availability and accessibility of treatment. That is true. Women with HIV infection are at 6 times greater risk of having multiple high-risk HPV types associated with development of CIN2 compared with women without HIV. Next, following gases are used as refrigerant during cryotherapy except oxygen. Next, factors influencing the success of ablative treatments are all except the age. Next, selection criteria for cryotherapy are all except that ECC is positive. Equipments needed for cryotherapy are all except diathermy unit. The ice ball formation during cryotherapy should extend by 1 to 2 millimeters beyond the probe margin. Diagnosis of carcinoma in situ warrants cone biopsy. The best test for cure is HPV test, which is not true about interpretation of SWEET score 4 to 5 low grade. The electrocautery setting for using LEAP device is blend. Normal squamous epithelium is translucent pink. The risk for cryotherapy is small, but complications can occur. These complications may include all except nerve damage resulting in loss of feeling. I think that completes all the sets of questions for tonight.
That's excellent. Thank you much. And now the last remarks from Dr. Lakshmi, madam. And kindly unmute yourself, madam. You are muted.
Priya, well done. You have performed much beyond my expectations. And because of you, along with your co-conveners, Mala, Bhagya, Revati, and of course, all the speakers and chairpersons, today I am a happy and satisfied soul. Because of your efforts, FOGSI ICOG, I am so happy that we could contribute a drop in the ocean towards WHO call for cervical cancer elimination. I know you have worked very hard, but it has paid a rich dividends in the form of all the appreciation messages which we have received in the chat box, in our groups, in our WhatsApp thing. And so very well done, Priya. I am very happy. And friends, don't forget, I'm seeing many questions about the recordings. We will upload it within a short period of time on ICOG website. So log in on our ICOG website, and next month we are coming out with a 3-day course on endometriosis. Along with that, we are also running many web series like research methodology, Guru Mantra, tutorial, everything. Registration is free. Just log on our ICOG website, that is icogonline.org, to see our February calendar. Do log in, and happy learning to all of you. With this, I hand over back to Priya, because Priya only has to give as far as technical comments are concerned, it is Priya's prerogative to conclude and end this 3-day session. So Priya, back to you.
Madam, I am also a very doubly happy soul. Yes. Because really we were, wondering how it will go, and this is the first course. So we did a lot of, back and forth to get this, and cannot thank enough my co-conveners, Mala. Thank you very much, Dr. Mala, Dr. Bhagya, Dr. Revati, and of course, Jignesh and Nilima, and all the faculties who have really spared their time. They have really spared their time in this busy evening schedule when they have their busy practices and all that. So, and the delegates, without you all, these programs and all don't get success, So you all have shown so much of interest. So we are able to, give back to you. So thank you very much, and be connected, and looking forward for another wonderful series, ma'am. Thank you very much. Again,
thank you, Jignesh. You have really, Jignesh again has performed beyond my expectations. Very well managed the platform and the pre-test, post-test, Jignesh. Well done.
Thank you, ma'am.
So
thank you very much. And certificates, madam. Madam, about certificates,
certificate takes time because the rules were already announced. Many people are writing that we missed this, we missed that. So sorry to say that. Unless and until you fulfill those criteria, ICOG will not be able to issue you the certificate. But yes, whatever, you have become rich by the knowledge. So just utilize that knowledge, whatever you have learned in this 3-day course.